I'm indoors now. It was just so cold out there. And then it's just England, and it was, and we were in the room and it was 28 degrees in this room and there was about 30
I'll just say
it was just, oh,
apologies for a few typos in it.
Number 2 instead of number
Well, shall I get us started? Welcome. So, welcome everybody to the Merton CCG governing body meeting in public. We don't, I believe, have any apologies for absence. Is that right, Tony? Particular formal proper welcome to Andrew Lee, our new lay member for audit. So this is your first proper governing body meeting as a member of the board, so very welcome. I'll move us on to the first part of the agenda, which is 2.1, which is declaration of interest. So if we just look at that, can everyone confirm that their declaration of interest is up to date and accurate? So yes? Marek.
I just wanted to mention that I have already emailed Tony that I'm no longer a governing body member at the Nelson Medical Practice, which it still lists that I am, but that's a minor issue, but nonetheless.
that has been checked.
So they've been changed on our register, just not the one for the purposes of these of this meeting. Okay. Thank you then. Let's go on to section 3, which is the minutes of the previous meeting. So this is for approval. So we've got two sets of minutes actually. We've got minutes from the September governing body meeting and minutes from the October meeting. So first of all, the September minutes for accuracy. Is everyone happy that that's an accurate record of the meeting, or were there any issues? Julie?
Sorry. On 4.1, number 2, it's got JH. I'm not sure who that is. That's me. It's you.
Julie Hesketh, yeah.
Oh, so we need to, we need to differentiate between Julie Hall and Julie Hesketh, yeah.
Most of them have JHE if they're you, don't they?
Yeah.
JH is meant to be you.
But
it was JHE, was it? Is that what you're saying?
No, yeah, it's JHE, but I'm JHA now, since
okay.
We've got so many.
So JHE was the one who was looking into how the CCG could be more visible. Yes.
Thank you.
Clarified that. Marek?
Thank you, Chair. In para 10.3, there's a minor typo. We were talking about themes rather than these. I think it just makes more sense for the paragraph then.
Well spotted. Anything else? So we're happy to accept those September minutes as accurate. Good. What about the October minutes? So 26th of October minutes, again for accuracy. Marek?
Sorry, very briefly. Neil McDowell and I have both been allocated MJ as our abbreviation. Not quite.
I think that must be a typo. I'm assuming Neil is NM.
Yeah.
Okay. Anything else? Anything of substance in the minutes? No, we're happy that they're accurate. Okay. So that was a short meeting, the October one, but we'll mark those as accurate as well. Thank you. Okay, let's go on to the action log, which picks up the actions from both meetings. So if I can just take us through that. The first one from the 25th of May related to the terms of reference for joint safeguarding arrangements. Julie, were you expecting to tell us something about that?
Yeah, what it is, we joined the two safeguarding teams together in February, and there was a commitment that we'd do a review on those arrangements. So I've just this week spoken to someone who's potentially going to be able to do that review. So my intention is to take what I believe the terms of reference need to be to Merton's Quality Committee next week. And we can discuss that with the GPs who have got an interest in that. So it can probably come off here. unless you want me to give an update. I seem to update and say this at every time.
No, I think that's fine if it's going to come to that meeting.
And we'll pick it up at the
that's
Quality
okay.
Committee.
Fine. And it was Karen who had raised that point. Okay. Okay. The next one from the 27th of July was about the variation in mental health services, and particularly asking about making mental health more visible at the Clinical Quality Committee. Did you want to say something about that?
So, I mean, Claire chairs that committee. I know that they had a focus on mental health at the previous Quality Committee. I can't see Claire. At the previous previous Quality Committee, and then we talk here around bedding and doing some work in our equality plan, and we have now got a child-specific objective that we're proposing, and we took that to the patient engagement group, and it's going on Monday to our staff forum, so we've progressed that as well. I don't know whether it seems to come on every month that I give an update, whether that's appropriate that I give an update every governing body meeting on this area.
I think we just need to know that going forward. It's going to be perhaps more prominent in the clinical quality process.
Yeah, I think if it's in the equality objectives, then that's a 3-year plan that we would work towards, and we'll talk to the lady that offered to support us with that, who came and told a story.
Okay. I mean, the other part to this was about Josh. You were meeting with the clinical leads for mental health for Merton and Wandsworth, and it said these had gone well and work was ongoing. Did you come to any conclusions in terms of the variation and what kind of work was required going forward?
So some of that might get picked up in the commissioning intentions item later in the agenda. The other thing to add, which was an action from I think 2 or maybe even 3, was there was a sort of a challenge to go and spend some time seeing the mental health services locally. I spent an afternoon in Springfield Hospital, including some time with the CAMS team. It was really informative. So I think it's worth minuting. Thank you to South West London and St George's for organising that and allowing the time of their staff for that.
Okay, thank you. The next action related to IAP. Now we've got that on the agenda, so I'm assuming that this is going to be covered in that update, is it? Okay. Next page was about winter resilience and a more detailed report. We've got that on the agenda, so that will be covered then. The next action was emailing a copy of the commissioning intentions process document to the Keepar St Heliers Hospital group.
So that's one where the minutes and the actions don't quite match up. So that was in the papers last time, so it's available. The discussion was on the commissioning intentions document itself, which is in the papers today. So after this discussion, I'm happy to email it to whoever might want it. Okay, but I assume they've got it now as it's on the agenda. That's fine.
Okay. Penultimate action was about GP practices providing complaints data to the CCG. So this was really around our, it related to the complaints PALS report, but I think was also probably part of our increasing focus on how we look at quality in general practice.
It was, yes, and I think what we wanted to do was present that data as we do with other providers' data at the Quality Committee. So I haven't yet, but that's why I was trying this earlier, to talk to Marek about that as the LMC, just to see if there's any concerns with us doing that. Because it doesn't go to us at the moment, it goes directly to NHS England, the complaints data for GP
So you can maybe pick that up after the meeting.
Yes. Yeah. Hang around, Marek.
Okay. And then the final one was there were some specific questions at the last meeting that were submitted in writing, and they required a bit of work to pull together a response. I have now seen a written response, but I don't believe it's yet gone, but it will be going in the next day or so. So just to say that has, I know, been actioned, even if the question hasn't yet received the written response. I know it's nearly concluded. So that is that's it for the action log. If I can go on then to 5.1, which is my chair's update. So apologies for a few typos in the update, but hopefully you got the gist of the key items. There was a report from the Merton Health and Wellbeing Board. Just a note that the clinical senate is happening this coming month. We're doing some really important work around clinical leadership development, which is it's been difficult to move that forward as we were coming together as Merton Wandsworth and thinking about how we do that as a joint piece of work. We have had Rebecca Thornley come in and meet with a number of our clinical directors and clinical leads, and those meetings have been very productive. And that's to think about what development we need to provide to our existing clinical directors and clinical leads, but also how we more widely start to think about clinical leadership development. So I'll be meeting with Rebecca next week, hearing what's come out of that, and fairly soon after that she'll be pulling together a recommendation for us around a proper clinical leadership development programme for Merton and Wandsworth CCGs. The final thing I wanted to say that's not in my written report is some of you will know that the week before last, 3 of us who are leaders in South West London, so myself as co-chair of the Clinical Senate, Jed Curran, who's the Chief Exec of Merton Council, and John Goulston, who's the Chief Exec of Croydon University Hospital, were fortunate enough to enter a programme of strategic system leadership development, which is run by Yale. So we had a residential week in Hertfordshire, and one of the parts of this programme is that we have to come up with a project to deliver across South West London, and then we have to report back in July to Yale about our progress. There were 3 leaders from STP areas from 10 different regions across the country. We were the only ones from London, and it was a very helpful week. We went thinking that the problem we were going to look at was the length of stay of patients in hospital, but actually having that's all right, having worked on looking at some problems as a group and going through some methodology and coming back with a presentation to the group on children and young people's mental health, we felt compelled to do something about it. So when we started to look at the rising instance of self-harming behaviour in our children and young people, and we know that is a significant issue across South West London, sometimes culminating in young people's suicide, we felt we had to take some action, and so we have agreed that that is the problem we're going to focus on as part of our project, which is self-harming behaviour in children and young people. It's going to require us to get together a reference group from a number of different sectors, including local authorities, schools, public health, CCGs, and the mental health trusts, as well as the voluntary sector. So we will be convening a wide reference group in January to look at the problem and the objective, and to do a bit of root cause analysis before we then pull together a strategy. We're very much doing that in partnership with Sarah and her team, and we'll be getting some support from that team as well. But I'm very excited that that's what we've picked to do. So that's all I've got to say in my update. Shall I hand over to you, James, to do your Managing Director's update?
Thank you. So I'm not going to go in detail through each of the items in the written paper. Just very briefly where we're up to in terms of looking at the way of working across the CCG and partners across Merton and Wandsworth, and also South West London Alliances. We're very close to concluding the piece of work to look at our staff structure. It's been a really positive piece of staff engagement. I also note the really positive work we're making towards streamlining some of our governance arrangements as well. I think that that's a complex piece of work. It's really important that we maintain the ability to focus on CCG and borough level issues, but at the same time we use the strength in depth across Merton and Wandsworth and across the South West London Alliance where appropriate, to make sure that we're really bringing our weight to bear, and the support of lay members in harmonising those arrangements is really appreciated as well. I talk in the report about the elective care recovery programme at St George's, and we're continuing to very actively support St George's around some of the challenges they have in elective care access, and much of the transformation work that's led by Andrew through the Plan Care Delivery Board is now focused on ensuring that there's appropriate capacity to treat patients in a timely way. Also worth bringing to the governing body's attention that an STP discussion document will be published later today, which is the start of the next phase of the discussion around the STP. and that will be circulated to governing body members when it is published. We've started to make really strong progress working with partners in primary care, community care and social services at the London Borough of Merton towards how we improve the integrated care model for residents in Merton, and particularly for our elderly residents and for other groups who are at high risk of hospital admission. And that work is taking place through our what we're calling our multi-specialty community provider programme board, which is a group of all of those partner organisations, which is saying how can we work together to more effectively integrate care across health and social care settings. And that met for the first time on Monday, and that's a really well co-owned piece between ourselves and the council. And the first thing that we're looking at there is how we develop what we're calling the integrated locality teams model, which is basically the multidisciplinary team composed of primary, community and social care, which targets people who are at high risk of hospital admission, and that ensures that we have a care plan for that group of people, that everyone is working closely together around that care plan, and that all agencies work proactively to put the support that people need in place to avoid admission into hospital. So that work is underway, and we'll start to get some implementation early next year, and I think that's a very positive piece of work that I look forward to bringing back to the governing body. The final point on the written report is the Epsom and St Helier strategic outline case. So earlier this month, the Board of Epsom and St Helier University Hospitals NHS Trust considered and approved their strategic outline case. I think what's important to emphasise from our perspective is that working alongside Sutton and Surrey Down CCGs, we'll look really carefully at the strategic outline case, at the issues that have been raised by the Trust, and what will follow will be a commissioner-led process to look at the challenges, to look at what they've put forward, and to perform a really robust and inclusive process that will look at all potential scenarios, the quality of care, the finances, and the issues relating to specific populations that are served by those hospitals. And of course, that will be a process that the governing body will be heavily involved in, given its responsibilities in this area. The final point that I wanted to make, which isn't on the written report, members of the governing body may have noted that we've published a statement today on our website regarding Ravensbury Park practice in East Merton. Now, Ravensbury Park practice received a CQC inspection in January this year and was rated as inadequate, which is one of the ratings that CQCs can give a practice. They received a further inspection in September, and the CQC has noted significant improvement in a number of domains, but their overall rating of the practice remains inadequate. We've been supporting the practice since the January inspection. That support continues. I'd like in particular to thank Dr. Karen Worthington and Andy McMillan and his team for the significant support that they've been offering the practice, and the practice is now making some rapid improvements, supported by closer joint working with a local practice, which is Wideway Medical Centre, and we're working really closely with the CQC to oversee that plan to make sure that it addresses the areas it needs to, and that it does so in the most timely way possible. So worth bringing to the governing body's attention, I think, but worth also providing the assurance that we're working really closely with the CQC and the practice to make sure that the issues raised have been addressed.
Thank you, James. Sarah? Okay, so covered. So, first of all, are there any questions from members of the governing body relating to the updates that you've just heard? Anything you wanted more information about? Claire?
Could I just ask about the multi-speciality community provider programme board and how much patient involvement, public involvement is there perceived to happen on that?
So it's only met once and on Monday, and one of the discussions we had there was about how we should do that, really. We are going to start by having Health Watch Merton present and sitting on the board, and the plan is to engage Health Watch Merton in looking at what more detailed involvement we need in each of the areas of the work that will be taken forward. Now, where that involves service redesign work the CCG is doing, I'd expect us to use some of our existing structures, so the patient engagement group, etc. And it's really important that we do that. But from experience of these pieces of work, you need some quite significant involvement, and we're hoping that Health Watch will help us to design that.
Any other questions? No. Okay, so moving on, if hopefully people have got the latest version of the agenda, what we've done is something we discussed in our Governing Body Part 2 meeting last time in terms of how we structure our agenda. We've got a section now which is general questions from the public, and that's really about anything contained in the updates that have just been given, or any general questions about things that aren't on the agenda. We then have a separate question slot at the end of the meeting, which will be an opportunity to ask questions specifically about things we've discussed as part of the meeting. So I'm going to allow 10 minutes for general questions from the public. We haven't had any written questions in advance, so one of my requests would be that if people have questions they want to make sure get answered, if you're able to submit them in writing in advance, it means we can prioritise them and also make sure we've got the information to give you a full and accurate response. But if I open it up now, shall I come to you first? So, thank you for sharing that, and I'm sorry. No, I know. So I think we recognise that Children's Mental Health Services is the service provided isn't as good as it could be, particularly around the capacity to treat children and the waiting times. It's a national problem, but it's something we have to fix here in Southwest London. One of the reasons for looking at self-harming behaviour in children and young people is we recognise that there are a number of root causes, and by focusing in on a single issue, when we delve down into the root causes, we will be able to think about what the most effective ways of improving that will be. I imagine it's going to involve, extra investment in the services. And we accept that, and it will be a big challenge for us as a system, really, which is if we acknowledge the scale of the problem and really want to do something about it, we're going to have to make a concerted effort across different agencies and put some resource and time into it. So I accept the challenge. We will make some progress.
Could I just help answer on? So there is a charity set up by Beth who came and presented to us a couple of months ago now. She set up a Hearts and Minds charity for young adolescents and people to talk to, and they've just got some increased funding to offer more sessions. They work a lot with the Sunshine Cafe, Crisis Cafe in Wimbledon. For an adolescent resource where commission services aren't filling the gap, it just might be worth just looking at some of the local... I think so, yes. Yeah, I think very much so. It's very much aimed at the younger person through into perhaps early 20s, so absolutely.
So, Sarah, I'll let you just say something on that
and
as
just
well.
Also, and it doesn't help you now, but I think we're refreshing the Sustainability and Transformation Plan for South West London. That will go on the website today, and if you look at that when it goes on, we've identified across South West London with all the partners that children and adolescent mental health issues is an area that we will want to prioritise over the next year or so, and that we want to work together to develop a plan to deliver some more support into that area, because we absolutely recognise that it's an area that we need to support in a different way to the way we are doing now. I know it doesn't help you today, but I think what it does do is it says this is a really important issue for us in South West London, and we're trying to listen to what you're saying and to move that on and get us into a better place.
Josh, did you want to come in on that?
Yeah, just on the point of the email contacts, I'm really sorry about that. I don't think I was given your email address. No, absolutely. So I apologise for that. If at the end either I'll come and get your email address, or if you could pass it to one of my colleagues at the back, maybe Michelle, I will email you tomorrow morning, and then we'll organise something. Okay, if you could leave it with one of my colleagues at the back, so Michelle's waving her arms in the air, then I'll email you tomorrow morning.
So I know I've got another 2 questions. I definitely will take both of them, so don't worry.
My name is Anthony Sperrin. I'm a resident of Wimbledon and have been for many, many years. I was asked to come along to this by the good folks at supporting St Helier, and I am very, very concerned about what is happening to the health service. I hadn't had a chance to investigate who was on this board and exactly what it did, but obviously you've got a very useful job to play in the National Health Service. Now, as far as the National Health Service itself is concerned, it seems to me that we are under a government that is systematically trying to destroy it. And they are cutting it back and cutting back the extent of the services that will be available to members of the public who are in need. So there will be a slicing of little bits here and little bits there and privatizing this and all the rest of it. Now, I think this board ought to be whiter than white and cleaner than clean in terms of defending the National Health Service. So the question I was wanting to ask, and I won't embarrass any individual here by asking them individually, but it may be something that ought to come on the register of interests. Does anybody have private medical insurance for themselves? And if you can't answer it, don't worry, just think about it and see whether it is a proper question or proper matter to register in your register of interests. Because there's a conflict of interest. If anybody has got private medical insurance, they are fighting against the National Health Service. I'm sorry, but that's my point.
So we will have a think about that. I understand your opinion on that. I think what I would say in response is I can say one thing for certain about everyone sitting at the table is that everyone here is very passionate about the NHS. I mean, that's why we do the job we do. If we didn't really believe in it and want to preserve it, we wouldn't be spending our time in the roles that we're in. And I think I can speak for everyone here on that.
Then we should fight the government to the hardest possible extent we can, and not to rubber stamp anything that might come from Simon Stevens at the top.
So certainly our role here as Merton CCG governing body is to look at the health needs of our population here in Merton and make sure that we're doing everything we can to improve the health and well-being of people in Merton. So when we come to look at the issues around Epsom St Helier as part of the process that we've described in terms of Merton, Surrey Downs and Sutton CCG, looking at the clinical sustainability issues at Epsom St Helier, we will be thinking about the needs of Merton residents, that's our role, and making sure that we think about what needs they have for services in an emergency or services that require a level of care beyond what general practice can provide, and we'll be thinking about access for all our residents to those kind of services, whether that's in a hospital or in a community setting. So you have our commitment that we are here to look out for the healthcare needs of people in Merton, and we take that responsibility very seriously. Shall I come on to your question?
It's not so much a question. I'd like Kosh petition to the board. Can I do that?
Yep.
Thank
yeah.
you. Can I come up front to do it, because I quite like it on camera?
Sure.
Can I put that in there? I don't know if anyone would like to come up and help us hold the banner while we do this, please. That would be nice. Hold the banner would be good.
Turn it round, Sandra.
I don't know if anybody
Sandra,
wants,
turn it round.
I don't know if anybody wants to come and take this up with me, but
Could I just ask that you don't, we do have an agreement that we're filming and live streaming, so we have asked that we don't have other means of filming. So could I ask that you don't, because
we're only filming us, we're not filming any of the public.
well
Often your film doesn't actually come up.
you're capturing members of the board, so just as
Well, it isn't meeting in public.
we have been clear about that, and one of the reasons we do the live streaming is because then we get around the issues of what to do around other people filming.
Or it doesn't work. And that's happened several times.
And we've worked really hard to collect this petition. We would like it on
This
record.
is a one-shot. We can't afford to. Sandra, turn that box round, please.
No, I'm presenting this petition on behalf of Kosh, and despite our name, the Keep Out St Helier Hospital, we are fighting for both hospitals. We are fighting for retention of acute services at Epsom and St Helier, and we're presenting it to you today, a copy of one of the CCGs in the area after the Epsom and St Helier Trust have announced the results of their engagement process. During their process, which went on for 4 months, they received just over 1,000 responses, and only 800 people apparently agreed with their aims to close acute services at Epsom and St Helier, and in fact they only got 400 supporters in that, and only 441 named individuals supported their plan.
Sandra, I think what's not fair is you're taking up the question time, where people might have questions about other health matters, and it's not fair. If you want the photo, if you want to take the opportunity to present it to the board, that's fine. But to read out a statement and take up time where other people might have important questions, I don't think is fair. I think it's important that you've made your point.
This is about life and death.
But I don't. I think the issue is, if you've got a question about it, we'd really happily answer that. But at the moment,
I'd like to tell you why I'm presenting it to you. That's all.
Please do.
Thank you. We're presenting it because we've talked to people on the streets. We have engaged massively, far more than the trust have. And in fact, we have got the signatures, the names and addresses of 10,775 people in this area who are desperately opposed to this plan. They think that lives will be at stake if this goes forward. They think people will die in queues waiting to get into hospitals. People die on longer journeys to get to a smaller acute hospital, which will be further away from most people. It will only have 500 beds instead of the 700 and odd we've got now. People's lives are at stake. BSBB was the same plan. This is being done under STP, which is about cutting costs £1 billion in our area, and we will not allow this to happen, and we will fight it tooth and nail, and we will win, because if we don't, people will die. And I would ask you, as doctors, to look to your Hippocratic oath: first, do no harm, and take advice from Chris Grayling, who was the Secretary of State for Justice, who told Epsom CCG at the end and the closure and collapse of BSBB, go home, take individual legal advice to make sure that you won't individually be held legally responsible for the lives lost due to your actions. Thank you.
Thank you. Okay. No. Shall I take that? Did you want to say anything in response?
No, we'll just accept it, I think.
Okay. Another question. Do you want the microphone? Should we get that for you?
Thank you. Under the recent budget, the government just announced that they were going to be giving 10 billion to infrastructure. I mean, presumably in the review that you're going to now be taking, is that something that you are going to be taking into account, that the government have offered, is offering significant sums for reinvestment in hospitals?
2.8. So the issue about capital for the
So obviously any announcements around capital are welcomed by the NHS because we have infrastructure problems in all sorts of places. Talking specifically around, if it's around Epsom St Helier that the question is based on, there's a huge amount of work to be done before we can get to a position to understand how much capital, where the capital is needed and how much and what the preferred option would be going forward. So we're not, I think, in a position to take advantage of something that's happening now, but certainly if we get to a point where we can agree that a decision is made and it requires additional capital, then we would be making strong cases upwards to Secretary of State for whatever option would be preferred. My view is that everyone can see that there's more capital needed at a number of our buildings in South West London, and therefore we need to make strong cases for those across South West London. So I think St George's, Croydon, there are a number of areas in South West London that need infrastructure investment. So we would, in South West London, support that wholeheartedly. So we'll get as much as we can through this process. I think as far as Epsom St Helier is concerned, I don't think we're in a position yet to be ready to say that we would want the capital and of what level we want the capital. So, but definitely for the future, I think.
I'll take one final question, and then I do need to move us on through the agenda.
Thank you. Dr. Murray, you mentioned about medical health, which we all know in this area is so bad and is worst in London. Now, I hope that's changing, and I take your statements, not only here but at previous meetings, that this is trying to be addressed as an absolute must. In other words, it needs to be addressed, and there needs more work being done because it's been so bad here in this borough. As you were on this seminar with Jed Curran, you'll know that you must have talked about some of these problems and the medical things associated with the social care, and I can only hope that's ongoing. However,
sorry, just to come in on that, I don't recognise the description.
You don't recognise the description? Well, everything's been closing here as recently as last year, year before. Norfolk Lodge closed. Now that's been happening over a period of years, and it's recognised out of the 33 boroughs. This is the lowest, shall we say, endeavour that's been had an input over the last 30 years in mental health. Now, if you don't recognise it, I can only say vast strides must have been made in the last 8 months that haven't been publicised. Now, that's the fact of it. So I can only say you have a lot of work to do in that area.
Well, we can pick up those particular points in the performance report later in the agenda, because we'll look at our performance and we can have a conversation as a board about mental health as part of that.
That can be, especially after in this latest budget. And so Simon Stevens was supposed to have said something about needing more money, wanting 4 billion. I don't know quite about this 10 billion this lady is speaking of, but it was 2.8 over the next 5 years. But either way, am I to take it that this board is making, shall we say, representations to the government in consort with other CCGs in the area, to government about the very strong need for more money in the NHS, and that certainly if St Helier is going to have, talking about another hospital, that's 3 to be maintained if what they say is true, how on earth are they going to afford another one on top of the 2 that are already there? Thank you.
So, shall I say something on mental health investment? So I think we recognise in the NHS as a whole that we historically haven't invested as we should do in mental health, and there is something called parity of esteem, and that's a national requirement for us to increase funding in mental health services, and we're fully committed in South West London to doing that. And actually I was at a meeting with NHS England this morning where we were talking about mental health services in South West London and how we might need to improve those and look at how we invest more. And it's not just about new money, because as you recognise, we don't have lots of new money coming into the NHS, but it might be about how we use that money in a different way. And we're working with the Mental Health Trust South West London, St George's in South West London, to make the best use of the resources that we have. And they're working closely across South London to ensure that we can, sometimes when we send people out of area, and actually to bring people back into area, provide services that are closer to their home, and also do that in a more efficient way, actually will free up resources to deliver more services locally. So we're working with them on things like that. So there's a whole piece of work that we need to do around making ourselves more efficient. We recognise we would like to have more money in the NHS, all of us, but we also recognise that all of our services aren't the most efficient they could be, and we have to be working together to make them as efficient as they possibly can be within the resources that we have. I'm not saying we wouldn't welcome more money into the NHS, because of course we would obviously do that, but we need to make sure also, from our perspective, that we have a budget, that we have to kind of live within our means, and we have to make the absolute best use of the budget that we have, and that's a key part of our role as a commissioner, and that's the piece that we're really focused on.
20 to 1 they voted at the BMA in Tavistock Square in 2012. We cracked them out 20 to 1 against this Health and Social Care Act, which has led to the present condition. And of course we all want more money, and of course we understand the so-called constraints, but representations must be made through medical bodies such as yourself to the government to gain any effect on that. Now you all know that. You all know that only too well, and we look at you with some suspicion, unfortunately, because we don't see that being effected by anybody, not only yourselves, but we see that how many beds there are. You talk about buildings being upgraded. Look at the lost hospitals of London. See how many have been opened in that time, and then see where you're going to go. And you don't have the money. You just said you don't have the money.
So I think I'm going to need to close the question time. The issue you raised about mental health, I think, leads us actually quite nicely into the next proper item on the agenda, which is about our commissioning intentions, because we specifically talk about what we're intending to do with mental health in that. So I'd like to move us on to that item, and I'm hoping that as we go through these next items, you will start to see some of what we are planning to do, both in Merton and across South West London. Josh, shall I hand over to you?
Thank you. Chair, if you don't mind, I'd like to take these two agenda items together, because they're very, very related to one another. So in your packs you have two papers. One is a version of the South West London commissioning priorities that we're asking the board to approve today. The other paper is a more local cut of in essence, the same strategy, which goes into detail on the progress we've made as of early November in developing the actual plans that support the delivery of that strategy. Now, the South West London commissioning priorities represent the second year of a 2-year plan that was approved last year. It outlines the expected changes across a number of different areas that are covered in the cover sheet for the paper. So that is namely urgent and emergency care, so responding to a lot of the new national frameworks in that area, but also ensuring that we have good proactive care for those that need it most. Developments in primary care and access, developments in mental health, making sure that we're spending the right amount of money, but making sure that we are investing in the right things from a preventative aspect as well at the acute end. We have cancer, planned care, maternity, LD, and integrated community care. Now, I'm going through this paper relatively high level because I want to go into a bit more detail when I get to the local cut of those South West London commissioning intentions. The other thing in terms of context is what is in this document was also shared with providers of services earlier in the year. That is, in essence, in layman's terms, I guess, a contractual heads up as to where providers could expect some impact on their operations. Normally that means things like we think that we can avoid people going into hospital for emergencies, therefore providers could expect a reduction in the number of people brought in by ambulances or attending A&E, or it might be that we think we can provide certain acute services more effectively in the community or via primary care, and therefore there will be fewer referrals to hospitals. It's that sort of thing. But in the national contract we need to give 6 months notice, and this information went to them then. I'll probably leave questions right to the end, and also James and Sarah might also want to add anything in terms of the South West London priorities. I'd like to move into the paper that covers the Merton cut of this. So the Merton Commissioning Intentions paper, again, so it's second year of a 2-year plan. So these are for plans that come in from April next year for until April 2019. The background and context is that clinical commissioning groups have to do annual refreshes of the plan. That's in part to respond to any changes in policy. It could be, but probably more, to react to any changes in the performance and delivery of our current programmes or services. And the paper outlines some of those. This is the first set of commissioning intentions developed by the joint management team across Merton and Wandsworth CCG. My hope is that that will enable us to scale up some of our plans by putting our collective heads together. It should also mean that we can gain more traction with providers that we share across the patch. So, for example, South West London, St George's Mental Health Trust and St George's Hospital. The other thing I'd add as well is when we're talking about some other providers in South West London, being part of the South West London Alliance and Transformation Partnership means that we can also influence what happens there as well. Section 2 of the paper outlines some of the key issues that we face. Many of these things we've covered in recent boards since I started 4 months ago. So we've discussed some of the demographic issues within the borough, an ageing population that drives activity in hospitals and other services much quicker than the background population because they're more likely to use services. We've also called out in particular the prevention framework. So even though after the Health and Social Care Act there was a split off of public health from the NHS to local authorities, we want to recognise, as we have always done, that it's an absolute joint endeavour in terms of preventing ill health. And so across the STP and across Merton and Wandsworth, we've been working with public health colleagues to identify where certain things can make a real difference to people's well-being. So that covers things like making every contact count, which is where professionals working with patients might spot that, for example, someone's smoking, and at that point offer them support to give up smoking, even if that's not what they're actually in a clinic talking about at that time. Also, as a significant employer in the area, having really good workplace health is a massive thing we can do to improve the health and well-being of the population. Moving into quality performance, again, a lot of this will come up in John's report on our performance at the moment. This picks out IAPT performance in particular for Merton. We're aware of some of the challenges at St George's Hospital, particularly around waiting times. The waiting times issue is also quite a technical issue when we look at certain changes. So we know that there is a long waiting list at St George's, so if we avoid referrals going into St George's, though that the capacity that would normally release is likely to be used to see some of those people who've been waiting longest. That's a good thing, and that brings down waiting times, but it does mean there's a financial implication for us in terms of what we need to save in the future. I also just wanted to call out something that I've been very impressed with since I've started here at Merton, which is the depth of the community engagement. There's strong community engagement at an individual project and programme level. Not this document, but a slide pack and summary has been going to a lot of different community groups. There's a meeting on Tuesday night that I'll be attending as well, where this will be discussed even more. It's going to many. The list is very long. I've picked out a few here, but it's a lot of time being spent by me and my team talking to local residents about these plans. The final thing to talk about, the next thing to talk about is that whereas the first paper, the South West London paper, outlines the broad strategy, the delivery of that strategy, as well as resulting in quality and performance improvements, also needs to deliver financial benefit in terms of efficiency in the services we commission. Now, the idea of these commissioning intentions is that through improving services, we will save money through the avoidance of things like emergency care, unnecessary hospital treatments and things like that. And that's what this table in the paper is meant to demonstrate, is by programme area, the types of things we're looking at doing, what we think that will do in terms of quality impact and our current estimate on the financial impact. Just a note for the minutes on the financial impact figures in here. This is for Wandsworth and Merton, because when this paper was written, the modelling was done once across the two. For each of these figures, roughly between a third and a half is for Merton. The total in this adds up to 15.8 million. I'm happy to be able to say that over the last month we've added between £1 million and £1.5 million to that figure. It isn't enough. The overall financial challenge for Merton is around 14 to 15 million, and that's net. So if we want to make any additional investments in services, we need to make sure that we can realise some benefit for them. So rather than going through every single line in this document, because there are a significant number of things, I'd just like to pick out some of the key themes we're addressing. So first of all, we know that if you have complex needs as an adult or a child, that they're best addressed through proactive care. The NHS for too long has been a service that responds really, really well to emergencies, but stopping those emergencies happen has been something it's been less good at. So a lot of these plans are trying to stop that from happening. That's obviously much, much better for the individuals involved. It should avoid trips to hospital. It should avoid some deterioration of their conditions. It also saves a lot of money for the system. And that's an example of where this should all be win-win. The other thing, though, is that there are people, of course, who need urgent or emergency care or care quickly, and where they do, that needs to be made as accessible as possible. So if people need to see their GP, we want to make sure they can do that quickly and at a time that suits them. If people people need to go to A&E, then we want to make sure that A&E is freed up for those that need to be there so they can be seen in a timely manner. Similarly, for some of our specific populations around, say, older people, those at risk of admission, we want to make sure that if there's a problem with those people's condition, they know who to ring quickly so that they don't need to end up in hospital with possibly a long length of stay, and all the evidence suggests that each stay in hospital deteriorates overall the condition that people would have. It's much better to avoid those times where possible. Because of the discussion before, I'll probably flick through and settle more on mental health. Now, I've got to say, I always feel slightly uncomfortable having separate mental health sections in these types of papers, because really what we should be attempting to do is make sure that mental health is given true parity of esteem. I mean, the policy is largely about the money, but really it should be about making sure we're looking after people's full health and well-being. So, for example, in the work streams around older people, we need to make sure that those integrated locality teams have good, strong input from mental health professionals to support their well-being and their care package. The mental health section in here picks out where we're doing specific things around mental health, so it's not exhaustive, but it includes things like, so we've commissioned this year, as part of the South West London initiative, a crisis cafe and a psychological decision unit, and apologies for the acronym in the paper here. The crisis cafe is meant to be a place where people who are experiencing mental health crisis can go for support, where in the past they may have had to go to A&E. Now, this has been in place now for 4 or 5 months, and the anecdotal evidence has been extremely powerful. That it's well used, and we've had very good feedback of the quality of care, and what we're now looking at is evaluating that to see what difference that's made on the overall health system, because if that's avoiding people going to A&E, that's absolutely good news for everybody. We've talked about improvement in access to IAP services. I think we'll come to that later in terms of some of the immediate actions, but we will be looking to make sure that we're commissioning services that are accessible and get good levels of treatment rates. CAMS, so one of the things that I was very pleased to see from the discussion document in the STP when it comes out later today is the focus on children and adolescent mental health services. That absolutely aligns with what we want to do locally. We're looking to improve access to crisis response for those services, and also making sure that we have really, really good access to behavioural support packages for children and young people. In addition, we're looking to try and bridge that gap between improving access to psychological therapies, access in and of itself, to make sure that that can be part of a more broader mental health response, mental health response for people with long-term conditions. The final section just sort of talks about what some of the next steps are. So we know that we need to go further with these schemes. some of the benefits of these schemes haven't been fully quantified yet, and that's where a lot of the work is focusing on. There are also other projects that we're looking to expand that we think could have a greater impact. So, for example, St George's Hospital are developing a business case for ambulatory care. I've seen an early draft of that. We'll be working with them on developing that. But that has the potential to massively avoid emergency admissions for people who turn up at A&E with ambulatory sensitive conditions such as respiratory conditions and so on and so forth. We will be reviewing our performance against other areas. You know, we're not, well, I'm personally not afraid of stealing other people's ideas if they're good and they can be applied to this area. And we will be making sure that we're getting the best value out of all of our contracts to ensure that we meet the challenge. Section 4 is on provider development. James mentioned this before, but I think that this is one of these things that's possibly a bit healthcare policy wonky, but is really, really important. So often what commissioning intentions will talk about is where pathways or services might change. This piece of work around multi-specialty community providers is about how providers work together to tackle the challenges faced by a given community or population. At the moment, the way that the framework in the NHS is set up, providers deliver contracts that we commission. We need to work better to make sure that that commissioning encourages joint working between, for example, mental health and physical health services and also partners in social care and education. We had the first meeting of that programme on Monday, which you mentioned before. It was, for the first meeting of something I thought incredibly successful, a lot of energy around the table, and there's been a lot of turnover in the area recently, and I think people are really, really encouraged that everyone seems to want to work together to improve things for the residents of Merton. So finally, in terms of next steps, we will continue to develop our commissioning plans throughout the autumn and winter. That's both coming up with the plans, it's negotiating with our provider organisations, and then it's looking to deliver them as soon as we possibly can. That will then form the basis of updates to the board in things like our quality and performance reports, and also the delivery of our financial position. So I think I'll stop there and take any questions. Thank you.
Thank you. So, questions from the board? Is there anything you wanted to add, James and Sarah, or not? No.
I mean, no, I think it's helpful that Josh has outlined the context of the process. I think just to say something about the sort of broader planning process, we're now into the process for planning for 2018-19 of identifying, you know, where we stand against constitutional standards and all the issues that Josh has identified, but also the need to plan against the budget that we have for next year. What we have identified here is a number of areas where doing the right thing will help us to address the growing pressure and the growing demand for services that we have, that puts a financial pressure on us because the demand is growing ahead of what we anticipate our budget growing to be. But we'll need to look at that in more detail when we scrutinise the full annual plan for the year early in the new year, to say, well, how do all these schemes stack up, and what's the overall impact, and what does the whole operating plan for the CCG look like? So just to put it in context, the process, this is us, you know, talking about the things that we're planning to do and the impact that they might have, but we'll need to have a broader discussion in the new year, which is what's the whole operating plan for the organisation.
Dagmar.
Yeah, I just wanted to also add that the plan was very welcomed at the Health and Wellbeing Board, because that is another means to try to link up as much as possible the work between the health service and the local authority. And the more we can share early on our plans, the more likely it is that we truly design the services that work for patients. So just to make that comment.
Claire.
I just wanted to reiterate the information about the community engagement. It has been exceptional this year and extensive. And I was at the patient engagement group yesterday where we had a presentation which was really welcomed. There was some interesting and robust discussion around it, and one of the things that was being said was that it appears very aspirational rather than practical. And actually what we've got today is a lot more of the practical as well as the aspirational. So I think we need to learn from that to really take out the practical stuff to people, because that's what they want to know. But they really welcomed the fact that we were engaging with them right at the beginning. And I suppose my question is, how are we going to take that forward, and how are we going to ensure that what has been said gets captured, gets put into the intentions, and then is fed back to people? We listened, we heard what you said, this is what we're going to do.
So in terms of the plans in the document, they are already the product of some of that in the past. We talked at the multi-specialty community provider programme board, and just to know, we will come up with a punchier name for it than that, about how we make sure that we move from engagement to co-production in the way that we deliver things. I think the practical detail of the delivery is almost always more what people are concerned about. I think often people will agree with the general thrust of things, but it'll be in the actual delivery where they day-to-day experience services maybe not quite working in the way that we'd hope. I would like to, as part of that work, to encourage all of our provider colleagues to agree a common set of standards for that. And so if we're implementing a new pathway or a new service, that part of doing that should be being really clear about how that plan's going to work. I'd be very happy to be taking regular updates on how we're doing as well against the plan to various community groups, if that's something that would be useful. Because I know that often people feel engaged with at the beginning and then don't hear it from it again. And I don't want that to happen anymore, if that is what's happened in the past.
So, Josh, just for clarity, the South West London draft commissioning intentions are on here for approval, and the Merson commissioning intentions, it says, for note or information. Are you wanting us to perhaps approve both?
So I'm asking for approval of the strategy. The individual plans and any investment and savings required will need to come back to the board for approval later in the cycle.
Okay. Yeah. So approval of the overarching strategy, noting the individual commissioning intentions as they're set out at the moment, but you're expecting to bring that back for formal approval. Okay. So any other questions from the board, or are we happy to move to approve the strategy and to note the commissioning intentions? Are we all happy with that? Yeah. Are we happy to do that?
Yes.
So I'll move us on to 7, which is specifically around the commissioning portfolio, and we've got an update today on the Wilson project, which, Andy, you're going to lead us through, is that right?
Yeah. That's right, and I'd like to introduce Lucy Lewis, who's the author of the paper you have in front of you, and Dr. Doug King, who's sat at the back, who's the co-chair of our programme board. Before I start, so I'll assume everyone has read the paper. That is obviously largely around the vision. And what I want to do, and what I'm really keen to do, is to turn the vision today into more of a reality. So I'm acutely aware that the conversations around the Wilson don't just predate my involvement in this project for the last 6 or 7 months, but probably predate my birth in 1983. And I think that is something that I'm very sensitive to, very acutely aware of. There are about 1,000 rumours flying around at the minute in terms of what is happening with the Wilson. What I want to do today is to provide quite a bullish assessment and quite a confident assessment of exactly what is happening, and to really give the view to the board and give the message to the board that actually this will happen. So it will turn from a vision to a reality. I want to just cover 5 brief areas covering the background and model, moving us on to talk a little bit about the governance, and then the timelines. I think it's important to address one of the questions that have been raised recently around the use of any space not required, and finally talk about the communications and engagement, because I think this is our first opportunity today to have this conversation and pull it for quite some time, and we've got a good story to tell. So just on the background, and I'll be brief around this, so the CCG committed to replacing the old Wilson site with a new health building. That was then led through Dagmar and Dave Curtis through Healthwatch, a whole series of community conversations with hundreds of different stakeholder groups as well, where it was determined that a health and wellbeing campus, rather than a simple health facility, was the best approach for East Merton, particularly given in mind, as we've already talked about, in terms of the levels of deprivation there, and also the health inequalities and that well-drawn link between the social determinants of health. What I do want to say and absolutely reiterate is that the health element will be every bit as good as the Nelson. So it will include X-ray and all the other diagnostics. It will be better than the Nelson because we're also trying to bring together the well-being element. So it's not health separate to well-being, it's really trying to address the person rather than the patient and to recognise those social determinants of health. So what do we mean by that? So for example, a patient who has diabetes, as Josh has already alluded to, we're very good at tackling the end result. So how do we manage with more medication? What we need to be moving more towards is saying let's address the reasons why that person may have diabetes in the first place, which principally around diabetes is around healthy eating and exercise. So if we have a space, as we will do at the Wilson, where we can bring together a range of groups, whether that's exercise groups, whether that's a community cafe or a kitchen run through the community and voluntary group, where we can start to educate people more around these areas, they're inherently starting to address some of those inequalities that have been brought about through the traditional means of commissioning. And that leads on to the point around primary care. So again, there have been a number of conversations around primary care, so GP practices principally. So we are not planning to have a GP list on the site. We've obviously gone through that with the closure of the Wilson Walk-in Centre. What we very much want to do, though, is to have a space, a very large space, flexible space, where we want to bring all the GP practices together using their skills with other partners such as Central London Community Healthcare, social prescribing, the community group, and really start to address the holistic needs of that person. So we've already identified in East Merton that we want to have an access hub where we have perhaps a lot of the same day general practice delivered from. We know that's a stress because we see the stresses on A&E day after day, but actually if we had a hub there where patients could see perhaps a GP, some of the social prescribers, somebody who could signpost and navigate them to other things that may improve their condition, then that in turn is going to deliver better outcomes. And it will also mean we can use all of the skills of the practices in East Merton, get them sort of coming together in a group work. So we've talked in the Primary Care Commissioning Committee this morning about primary care at scale. So how do we leverage all of our practices rather than try and treat them individually? So how do we get them working together more? And through this kind of approach, we think we can get better outcomes for the patients because we'll look at the best skills that are available from various colleagues and bring them together and again start to address the needs of the person rather than just of the patient. And Doug, I'm sure we'll get an opportunity to talk about this, has been doing an awful lot of good work with GPs and other stakeholders in terms of specific work streams around mental health, children's services, but again, very much part of the vision around addressing the person, not the patient. Moving on to the governance. So I think since the last update, what we have done at the Wilson Programme Board is establish, co-chaired by Peter Derrick and Doug, as I mentioned. We have representatives from NHS Property Services who own the site, also from community health partnerships who will be responsible really for leading the development of the new site and very much involving voluntary sector through Cadera, Dagmar through the public health angle and other London Borough of Merton colleagues. And this is really important because we're trying to make sure that we get the right health and wellbeing campus that's going to fit the exact population requirements of East Merton. And it's also really important because all of these stakeholders have a crucial role to play in making sure that this project actually happens. And the momentum that we've been able to get in the past 6 months in terms of getting everyone together on the same page, making sure they all understand the vision, has been really helpful in that regard. Moving on to timelines. We are aiming literally as of the end of this week to get the, if you like, the central approval from the NHS England London region. And now that's very boring speak, for essentially it means we can then talk to community health partnerships to do what's called request a new project. And this means they will work with us. They will have architects, designers, consultants wanting to work with us and say, so if you want to do X number of consultations or Y number of different sorts of consultations, this is how many rooms you need, and ultimately, of course, this is how expensive the mortgage will be. You know, it's not technically a mortgage, but I think in terms of lay people speak, it probably is a mortgage that we would have. We would be the head tenants over a 25-year period. We'd have to make sure that clearly all of the rooms, all of the sites, we have sufficient process to make sure that we have it filled as well as possible in order to pay back that mortgage. And I think it is very important to say in terms of the timelines, we are aiming to go to formal planning stage with the London Borough of Merton within around 12 months, give or take 1 or 2 months, which will then enable the build to be complete at some point in the year 2021. So we have a very detailed timeline worked up. We are going to publish this on our website, the programme board, terms of reference, and also the minutes as well. So we're trying to be increasingly transparent and increasingly, I think, really clear that this is actually going to happen. This is going to make a real difference to the residents of East Merton. The two final points. So one is around the use of any space not required, because this is something that has clearly been, I think, in the public domain for quite some time. I think it's important that I stress our first and most important priority is making sure that we get a first-rate health and wellbeing campus. And what we are doing for that at the minute is trying to establish exactly what we want, and then through the experts that we'll bring in with CHP, we'll then be able to identify how much physical space that will need. We absolutely have to prove financial affordability without the reinvestment of any capital receipts. In other words, the sell-off of any land that isn't required for the health and wellbeing campus. So clearly we want to be able to reinvest back into the campus as much as possible. And there is a process being led across London, which we are part of. It's a London Devolution Board, so that if there is any spare land available, then that money can get reinvested back into health and wellbeing campus, which overall makes it a slightly affordable, slightly cheaper model, which means that we can do different sorts of services with it.
We were told that that wouldn't happen at the closure meeting.
So hang on, what I've got is a section on the agenda for questions relating to things we've discussed. So I will give you time to ask questions relating to this or anything else on the agenda. But if we can go through the items without interruption, and then I promise you I'll give you space for questions.
So on this section, so for any space not required, and to stress, clearly we haven't identified how much space we do require, but for any space that isn't required, we are wanting to work very much with partners, so LBM, the community, to really understand exactly what the opportunities are for that area. Now, colleagues may know that actually the Wilson site has been earmarked for high quality affordable housing. And I think that's only right because we know there is significant evidence that high quality affordable housing has a positive impact on health. Now that is obviously a decision for the London Borough Merton Planning Committee, but it's also really important for the look and the feel of the overall site to make sure that we have not just the first-rate health facility, but anything else that's available on the site very much fits in with the vision that's already been identified. And finally, on the communications, so as I say, we spent the last 6 months working on the governance, making sure that we have all the behind-the-scenes momentum. We have refreshed the model, as colleagues will see, in terms of making it more of a health and wellbeing offering, which has been thanks to all the work of the people who have inputted into the process and the conversations that we've had so far. I think we do have a positive news story to tell in terms of how much we have listened and how much we are going to respond to that. I mentioned around the ideas of the community cafes, the real wellbeing element that's going to be part of this, so it won't look and feel like hospital, albeit it will deliver all the service available at the Nelson. And what we are going to do is two things. So one is the communications, which is the typical NHS approach, press release statements, a communication strategy, and making sure we're very proactive in that regard. And then we want to revisit the engagement approach. So Dave and other colleagues will be going back out from February to the community groups and various learning events to really start to share what we've been doing, and also to perhaps ask for a bit more help and support in terms of how can we be really precise in terms of, so what would a community cafe, what would a social prescribing element look like to the hub as well. So this is the first opportunity we've had for a long time to talk to the governing body today. I want to give my personal assurance that we have moved on an awful long way, not just in terms of the vision, but it's now about how do we turn that into reality, both through the governance, the relationships that we have established and continue to develop, and also all of the work around, I think, various people in this board as well. So I'm very confident that we are going to be delivering on track. I know that's a message that people have heard before, but I think from what I've seen, we've got all of the systems lined up in a row to make sure that this will happen.
Thank you, Andy. As you know, we've had some conversations and we are absolutely committed to making this happen. And I'm really pleased with the latest degree of assurance we've had, both at the programme board and at the Health and Wellbeing board, in our private conversation about it, that things are on track. I think it's really critical that we do deliver on all the health services aspects. So we've done a lot of talking about the wellbeing aspect. I think that's because we make the assumption that we're going to do all the health services on the site. So we know that, but I think in terms of how we communicate it, to be crystal clear that we are going to put all the required health services on the site. The reason we're talking about the wellbeing stuff is that's because that's stuff we haven't done before, and it's not stuff the NHS is used to doing. But increasingly, as we move to focus more on prevention and thinking about holistic care for patients, that's an element we really want to incorporate. Shall I open it up to questions or challenge or comments from the board? Doug, did you want to say anything, or Lucy, are you here for to respond to questions maybe? Okay.
Yeah, it may just be helpful because you talk about the wellbeing a lot, but maybe perhaps if Doug can sort of elaborate into that. And we have, Lucy has worked hard on a patient story, just to say how different it will be compared to perhaps how services are currently arranged for patients. So, but Doug, do you want to just perhaps elaborate a little bit more?
Sure, thank you. Do you want the microphone? No, it's fine. It's just because we're recording, so it would be helpful if you did have the microphone.
We have the mic. Thanks.
I will shout to them. Hello, thank you. Thank you for having me here as well. I suppose from my perspective, really thinking about the focus on the well-being is that it's really intertwined and part of health. The Health Foundation defines a healthy person as someone with the opportunity for meaningful work, secure housing, stable relationships, high self-esteem and healthy habits. And from my perspective as a GP, seeing some of my patients, there is a limit to potentially what I can do, but with a site like this, hopefully what that means is that we have got a wealth of fantastic experience in one location, and that can mean that we focus on patient empowerment. And we talk a lot about integrated care, we talk a lot about patient empowerment. From my perspective, it's really, as I heard previously before from Josh, it's about the patient being in the center, what's important to them and what it works. From my perspective, I can often give tablets, I can give more tablets, I can change tablets, or I can refer someone to give more tablets. And you know, what we don't do so well is thinking about the finance, the housing, the elements of employment, and things like that, which actually on site they can be signposted to or actually have the service of, can be incredibly helpful. And so we can potentially work in such a much more integrated manner. We can really focus on what's important to the patient, which may not be their health, although, you know, often I like to think it is. However, it may be in fact the fact that they have an issue with their children, it may be the fact that they're being bullied at work, it may be the fact that they can't sleep, it may be the fact that they're having some problems with regards to their mood, or it may be all of these, as is the case with some of my patients. And therefore, helping them select what's important to them and then working together will deliver a much more holistic approach to this, in my opinion.
Thank you, Doug. James, did you just want to say something specific about the timelines or the approach to how we work through things on the site before I'll open it up then to Karen and Claire? I know you've got questions to ask.
Yeah, so I just wanted to talk a little bit about where our focus is and how we're approaching issues around the site. And it's very much to support what Andy said. So our focus is on making sure we understand the service model that we want on the site in terms of firstly health services, wellbeing services as well, working with our partners at London Borough of Merton, and also how they'll work together. The next focus we have is to make sure that we have the appropriate estate to put those services in now and the future. So we need to make sure we've got the right buildings to the right specifications and that they're the right size. Okay. After we have done that, and only after we are fully assured and have extensively publicly engaged on that, is there a discussion about any remaining land on the site. okay? But we will absolutely make sure of that before we go into that discussion, and that is our focus as a health body, okay, to make the absolute most of that asset. So I just think it's absolutely worth laying that out, because that is our primary concern, and that's as it should be as a health commissioning body and working with our partners at London Borough of Merton. So just to be absolutely clear that, I'm sure we'll get further questions on it, but I just wanted to assure the board on that point.
Claire, do you want to come in, and then Karen?
Unlike Andy, I have been around a lot longer, and for the last 30 years worked in the east of the borough and lived in Merton, obviously. And this has been an aspiration. It's been something that we've been looking for and wanting. So I'm really, really excited that we're working so effectively together. And it's also the work that's been done with the community groups, with the voluntary sector and health, all coming together. All I can say is this has got to happen. We need this.
Thank you. Karen?
Thanks. I'd just like to support really what the point Claire's made, and also Doug. I mean, I've been a GP in East Merton for 26 odd years, and actually the health inequalities have between the East and the West have actually, despite all our best efforts, have actually not changed very much. So I think that's a really strong signal to me, and also to my colleagues in East Merton, that we need to try something different. And I think that this is a real opportunity to give patients a much more holistic approach. And actually there's a very strong evidence base, if you look at the evidence on this, that actually health only makes a very small contribution to people's long-term outcome and well-being. So I think this is a fantastic opportunity for practices and also for patients in East Merton. And I think we're seeing some early benefits already in the social prescribing pilots that's going on in 2 of our East Merton practices. It's being externally evaluated, so it's not being evaluated from within, and it's actually showing significant benefits for the patients that have had contact with the social prescribers. Thank you.
Dagmar?
I think that was precisely my point, that the aspiration, I think, was there all the time, but that the social prescribing pilot in East Merton is actually the hard evidence. And so that's what really inspires me. And I'm here now almost 2 years, and I cycle through the borough, and I pass that site quite often, and I think, God, nearly 2 years, what have we done with this site? There's so much need, and what little is actually done with this site. So I'm absolutely committed that jointly between health, local authority and community, we can turn that site into a real asset working for the community.
Steve?
I realise some of this is in the paper and you hinted at it, but could you give a further idea of timelines?
Yeah, so the formal timelines are that we want to have this built in 2021. So working back from that, it means we have to go to planning permission in about the next 12 to 15 months. So working back even further, we have about the next 6 to 9 months to work with various partners we've already alluded to, and CHP, who would help kind of design and ultimately help build the site with the lift company, to really address precisely, being very specific about the granularity of what exactly is going to be needed in there. Having said that, obviously this site is going to be fairly flexible, fairly generic, so that if in 20 years or 10 years' time we said we wanted to do something slightly different with it, then we could do as well. So it's going to be quite a nice open plan feel. It's not going to be walking into the Nelson, you've got 20 different rabbit tunnels to run down. It is going to have that wellbeing element at the heart of it, and those conversations we're obviously already had and will continue to have, to continue to develop as well. And obviously it will have the core, the cadre of the medical services, the health services to back them up as well. So just to very quickly then, so we're looking to go to planning committee in the next 12 to 15 months, and then obviously we'll be going on to appointing developers and getting the build, which might take anywhere from 15 to 18 months as things currently stand for 2021 completion.
Let me. We will come to your questions later on in the agenda. So I will. This was really a discussion item for the board. Andy, did you want to say anything in conclusion?
Just fine. I think I'm very keen to move the language away from this is an opportunity to this is going to be the reality. Obviously, a lot of us have been around for a long time talking about aspirations, visions, new visions, and now the work that we're doing, now we've got a lot of momentum behind this with the right stakeholders, is turning all of this vision work into a reality. And I'm sure the board sort of join me in that commitment as well, and that sort of changing tact really in terms of this status.
Andy, I'm just going to come back with you with one thing, which is I think probably what we've not been very good at is telling people what we're doing. So I think we have been very good at engaging with specific community groups in the voluntary sector and having lots of conversations, but in terms of us being crystal clear on a website or by communicating in public, I'm not sure we've taken people necessarily on that journey with us or are being crystal clear about exactly what we're doing. So what can we expect to see going forward?
So I completely agree, and that's why I alluded to it in my introduction. So we have a comms and engagement approach now. We actually have some new resource starting with us in January, which has been long awaited for this project. So we will do the press releases. We will do look to have one or two further meetings with the public as well, and obviously do the typical communication channels that we would expect. Which gets us to a point when it comes to communication, but we do recognise that we have further work to do, further engagement work in some of the community groups as well. So we've got a lot of good news to tell. We are going to tell it, definitely that's going to happen, and we've got some further engagement work to do with various community groups, which we're going to get on with early in the new year as well.
So if we were to reflect back at, say, our February board meeting, we'd be able to look back and really see the step change in the amount of information we're giving people.
Absolutely.
Okay. Sarah.
So, I mean, just to reiterate that, so since being new in this area, I think I've heard a lot of scepticism about whether or not anything will actually be delivered. And I think that the only way we as an NHS can prove that we can do this is to actually deliver it. I mean, that's my bottom line on this, is that we can only be judged by what we do rather than what we say. So I think from my perspective, there's something about the communications, but we also need to see real hard, solid progress that we can actually evidence to people on the ground. And I think that's the most important thing, because otherwise I don't think we'll get over the view that we have externally based on some of the history around this.
No, I agree. Okay, let us move on to the next item on the agenda, which is just the summarised minutes of the Audit and Governance Committee. Neil, did you want to talk to this? Because although Andrew is our new lay member for audit, he hasn't yet got to the point of chairing an audit committee, so I don't think it's fair to ask him about a meeting he wasn't at. Do you want to just pull out anything important for us from that?
Yes, I will. Thanks, Andrew. So you've got the notes actually in the pack for June 2017. So I wasn't planning on actually going through that in any detail, but happy to pick up any questions on that. We have met since June, so there was a meeting in September, so I was just going to give a quick update on the things that we discussed at that particular meeting. So that we noted and approved single tender waivers for Concordia, who were doing a one-off piece of work in terms of ENT services for treating some of the backlog patients that we have. We'd got Merton Health Limited, who were approved to provide the hubs into East and West Merton. We also approved policies for gifts and hospitality, and also the conflicts of interest, and also agreed the closure of the governance review and the financial action plan, which originated, I believe, 2 years ago. So that was closed off at this meeting. And then just in terms of the usual audit updates that we had, we did have a really useful update from internal audit around cyber security in the wake of the WannaCry cyber attack. So I think what we were looking to do is to maybe take some of the findings within that report and actually see how the CCG is faring against if anything was to happen in the future, and we'll do that in conjunction with the CSU that do our IT. There was no council fraud updates at this particular audit committee, as previously agreed with them.
Okay.
Thank you.
Thank you. So, any questions or comments from members of the board? No? So that was just for us to note, I think, although it says approval on the summary. I think we're just noting those minutes. So I will move us on to finance, and we've got the minutes of the 2 finance committees in September and then the month 7 finance report. Is that right?
Yes, that's right. So just to note, the 4th of September was actually the August Finance Committee, but due to leave, we had to postpone it till the 4th of September. So again, as the Audit Committee, I don't plan to go through those notes in any detail. You've got them there. If there's anything specifically you want to pick up, I'm happy to answer that question. However, I will just give some very brief notes on the last the last Finance Committee that we had in November. So it was the very first committee in common that we had with ones with CCG and Merton CCG. So we piloted that, and I think it went well in terms of how the meeting went. Just in terms of the content of the meeting, we'd looked at we'd reviewed the risk register, which was one of the asks of the audit committee, that we would look at the finance-specific risks. We also had a paper looking at the planning round for 18-19, and in particular noting the size of the ask, which was picked up, I think, in the commissioning intentions paper that we heard earlier. And we also then reviewed the month 7 position, which I will be coming on to shortly.
You want to go on and do the month 7 position, then we can maybe take any questions at the end relating either to the report or to anything you just mentioned relating to the minutes.
Yeah, okay. So I'm not planning on going through the whole report in detail, but what I'll do is I'll pick out sort of areas of specific interest that I'd like to draw the board's attention to. So just first of all, on page 4, you should see there's a scorecard there. I think it's headed LDU. It actually is, should be Merton CCG on there, so apologies for that, but it is a Merton CCG scorecard. Just to note that in terms of a review of our governance, that we've now created a finance resource oversight group. So this has replaced what was originally the finance recovery group and the savings delivery group, and we merged them into one meeting with a part 1 and part 2. And this one will operate across Wandsworth and Merton as well. And you'll also notice in there that the financial performance is that at this point in time we are still assuming that we will achieve our break-even position, but noting the risks that I'll come on to now. So if you moved on to page 10, which is the risk and mitigations table, you'll see on the left-hand side is the current reported position, which shows that we have a break-even position. What this flags is that we've got significant risks around the delivery of QIP, which at this, on the left-hand side, is what we are assuming is unlikely to be achieved. So we've already taken that into the position. There are general performance issues of which I've updated the board previously on those particular issues, mainly relating to price issues as opposed to activity growth issues that we've got. The mitigations, I think, are sort of predominantly around continuing care that we've got as an underspent budget, but also we've got the full utilisation of all the reserves and contingencies. Probably what is of more significance is looking on the right-hand side table, which is really the attempt to look at, so actually, if the further risks that we've not currently taken into our position, if they were to materialise, how might we mitigate those particular issues? So what we're predominantly saying here is that the QIP that we think will deliver on the left-hand side table, we're saying actually if that didn't deliver, what would we do? So the expectation is around some resource that we may get in to cover for the specialised commissioning transfer. So at the moment we're saying to NHS England that we are unable to cover that from within our position at the moment. There are other prescribing and other system issues that we've got in there as well, which again, in terms of the prescribing issue, we're saying at this point in time we are unable to actually cover that. So when you look at that table, you'll see that there's actually a £2 million shortfall. So if all the risks were to actually materialise, we haven't currently got the level of mitigations in place to cover that. So that's £2 million that we've got. So therefore, in the next month, we are going to be looking at where are those areas that we're going to be able to recover that should those risks materialise over the remainder of the year. Now, it could very well be those risks don't materialise, and I think this might be about just ensuring that we build in some cushion that takes us through to a smooth year-end. However,
sorry, I was just going to say, should we? I'll get you to pause at the end of this slide and just then make sure everyone's digested it, okay. and then you can go on. Sorry, but you obviously, did you have something else to say on this particular?
No, so it was really just about saying that this may lead us on to making some decisions that we wouldn't normally choose to do through to the end of the year. But yes, happy to pause there.
Well, let me just because obviously I go to the finance committee, so I think I understand this table, but I understand for some of my colleagues around the board it might not be immediately intelligible. So if I just perhaps talk through it and as I do, you can tell me if I've got it or not. Okay. So essentially, the left-hand side, what you're showing us in terms of the risks is what we're currently seeing. So we know that this is actually happening, which is we are not delivering our full QIP, which is our quality, innovation, productivity, and prevention schemes, which are designed basically to make us more efficient and effective in our use of resources. And where we don't see the full benefit of those programs we've got to try and deliver that, that's what you're seeing there, which is 2.6 million of schemes that we'd planned that haven't quite delivered what we'd hoped for. The performance is more activity largely at hospitals than we had planned for at the start of the year, and that's the 3.9 million figure. So that's essentially the total risk we know we currently have, and the mitigations is things we've actually done or got going on that should deliver us a reduced spend of about 6.8 million, which means that we're currently covering off the risks we know we actually have. Your right-hand side then is things we think might happen based on our understanding of the context we're currently in.
Yes.
And you're saying the worst case scenario based on what we know is that we might end up overspending by 6.6 million.
No, 2 million.
Okay, so we'll end up in a position where we're spending 6.6 million more than we thought, and then we will do, if we didn't do the things you've set out below, essentially.
Yes, that's right.
And just to clarify, so the risks you're identifying, QIP under delivery, same as the one on the left. Performance, similarly, that's assuming that we continue to spend more at the hospitals than we had thought. The specialised commissioning issue, do you want to just flesh that out a bit so everyone knows exactly what we're talking about there?
Yeah, so this was something that came up for this year, where specialised commissioning transferred certain services from being NHS England responsible commissioner to the CCG. And we did get some recognition for that in terms of allocation adjustments. But actually what's transpired is that the basis on which we believe the allocation was adjusted looks like it's flawed, because we seem to have got a significant cost pressure as a result of this particular transfer. So what you'll see on there is that we've got 1.2 million of risk, and then if you look under the mitigations, we are assuming that we'll get some an allocation transfer or some other way of managing that out of the system. Now, that's a piece of work that is ongoing at the moment, and we're hoping that we will get some conclusion possibly by Christmas, but I guess it might go through a number of iterations before we get to that stage. But that's ongoing at the moment. It's unfortunate that it's so late in the year because it's such a significant issue, and this is predominantly driven around St George's.
And the further mitigations that you're listing on the right-hand side are things we're planning on doing anyway, or we may or may not do, or may or may not come to pass, depending on the context. Is that
Yes,
about right?
The mitigations.
Yeah.
So the mitigations are a combination of where we'd written off all the quip. There's clearly a plan that was sat behind that. So what we've done is we've looked at the plan and said, well, actually, we really still are confident that we will deliver that. But then, therefore, maybe other plans that we know are not going to deliver. So we've had to come up with other schemes to manage that off.
And what you're describing is when you say in the next month we're going to look at mitigating that 2 million figure, is we're assuming a worst case scenario, so we're planning for it and we're seeing what we need to do to get rid of the risk, to minimise the risk. Okay. Andrew.
I mean, is there a probability that you can attach to this? I mean, what is the chances of this actually happening as opposed to all the mitigations and so on?
So if I'm honest, this is a bit of a mitigated position already, so we could completely red rate all of this and say that absolutely, in terms of the risk, that they're all going to materialise. But I mean, I think it's more, if I was being honest, it could be more of about a 75% chance. But we don't, you know, there is still some way to go. So, for instance, the specialised commissioning issue is very much in terms of the analysis that's ongoing at the moment. So that one I really don't have a feel for which way it goes. I think we've got a strong case, but it's going to be considered across London and possibly nationally as an issue.
James, did you want to come in there?
Yeah, I mean, just one of the things that's worth considering around that is that obviously we pay for what's treated in the hospitals with the contract structure we have at the moment. So we pay for when people go into hospital, we pay for individual sort of packages of treatment or outpatient visits or spells in hospital, and we're entering one of the busiest, or the busiest time of the year really for the hospitals. So one of the things that we always build in is an expectation that the hospitals will be busier in winter than they are in summer. Now, what we never not quite know going into a winter is exactly how much busier they will be and how that will affect, because it affects obviously workforce and money and activity and capacity in hospitals and everything. But it's never possible to forecast with a complete degree of accuracy how that will particularly impact on the money. So there's always an element at this time of year of building in a little bit of flexibility and a, you know, if anything, sort of planning for the worst in terms of the level of that activity, so that you can obviously be pleasantly surprised if that's not what comes to pass. But it's a difficult intersection of the business planning process and the time of year it is for a hospital service, because obviously getting towards the end of the financial year, you're in one of the most volatile times for one of the biggest factors that affects the money.
Julie, so I'll take your question, then maybe I'll get you, Neil, to tell us anything else you need to tell us and open it up for further questions.
Thank you. It's just with regard to specialist commissioning, was there a list that we had handed down to us to commission? And so has NHS England still got some of the specialist commissioning?
Yes, so it was a set of specific areas. So predominantly where we're seeing the pressures is around neurology, neurosciences, that activity that's coming through. The issues have been more to do with it. It's more of a technical issue, if anything. It's how you identify the activity and the time period in which that happened, and that's been the problem, because at the time when they did it, it was done with a certain software and a information at that time, and we've had updates to that particular, it's a group of software, so we've had the updates to it, and it's now ended up where we think it's a materially different result that, you know, that allocation would have been had we known what we know now.
So I'll just let Sarah come in, then we'll come back to you, Neil.
So I'm going to answer a slightly different question, because that's the kind of finance bit. I think on actual specialist commissioning, that still sits with NHS England. They did suggest that there were a number of areas that might come to CCGs at some point. We haven't actually been through a process on a lot of those yet. So I'm assuming that when we do that, we will need to make sure that the money follows the commissioning, and we'll need to make sure that the analysis that they do on that works and that we get the right level of money. It's always difficult difficult when you start to move money around the NHS, because you can never quite predict, because we pay on activity, you can never quite predict what it's going to be. And you know, we have kind of split up the budgets in the NHS, and therefore now we're sort of putting them back together to some extent. So we believe that this bit is actually, it's about how you measure what's CCG and what's specialist, rather than a movement of the whole of the specialist pathway. And we believe that there is a mistake on that, and that we can argue that and manage that with NHS England. But we have to go through that process before we can say that we will get the money.
Neil, anything else you'd like to pull out for us from the report? I just thought it was worth pausing on that table, because that really is the critical overview of where we're at.
No, absolutely. I could probably do the whole report just revolving around that particular table, to be honest. But just to pick up a couple of issues which are within that table, but just to put a little bit more detail in there. So under page 18 on primary care, there is a prescribing issue, and again a national issue that we've got, which is around certain generic drugs that are not being made available at this stage, and therefore more costly drugs are what is coming through, and that's caused a cost pressure, an unforeseen cost pressure at this time. At the moment, we're flagging it again as an unmitigated risk that we've got, but we don't know that this could reverse at any time. So we are looking at prescribing data, which is August is the most up to date, so we're 2 months behind from this report. And we have seen, so I do know that we've seen a slight softening in that position. So at the moment, we've put it into the risk of mitigation table with no mitigation against that as well. But to reiterate, it is a national issue that we've actually got with that. And then really the final point was really around QIP. So I think I've picked this up probably when we've been looking at, again, the risk of mitigation table, which is we've done a complete refresh and look at the QIPs. In terms of the plans that we think still will deliver, we're going at that. We're also looking at those schemes which have delivered, and can we stretch those further. But equally, there are some other schemes which we know won't deliver at all. The big risk for us is moving into 18-19, is where we're having to cover the programme with non-recurrent means, and so we do have circa £5 million of non-recurrent resource going in here. That then puts pressure onto the following year, because that means we have to still find that money in the year. So there's clearly a lot of work still to do around that before we get to the end of the year, but I think I'd like the board to be focused that even though we may achieve our targets and we may achieve our QIP, I want that point to be clear in people's minds in terms of the impact it may have for 18-19.
And Andrew, particularly for your benefit, because this is your first look at this kind of stuff, just maybe worth spelling out what the QIP programme is about, which is largely, it's meant to be about investing to save. So investing in doing the right thing and improving the quality of services, because we know that ultimately that will give us a better outcome and will end up giving us some savings. In reality, we also have a number of schemes in there that are about efficiencies and finding areas where we can reduce the cost in order to make the numbers add up. But our plan around QIP and our strategy is always to try and invest in doing the right thing, because we know actually it's more cost effective in the long term.
Okay, so just for the board to basically note the reports, but in particular the risks that were on slide 10 and that level of achievement, and particularly the non-recurrent coverage in 17-18, which will impact 18-19.
Any further questions or comments on the finance report? Are we happy to note that? Is that okay? Right, thank you, Neil. That was approved at Finance Committee, obviously. So,
Thank you.
I shall move us on to section 10, which is primary care, and we've got an update on the primary care strategy.
Yep. So I'm going to hand over to Rebecca and Karen in a moment. But I just want to say we wanted to bring this to this governing body because I don't think we've had a primary care update for quite some time. And as you can hopefully see, there's an awful lot of good stuff going on. So I'm going to hand over to Karen and Rebecca for a double act now.
Okay, thank you. So yes, as Andy's just said, the purpose of the paper is to provide the governing body with an update on the work that the primary care team have been delivering, particularly over the last year. The executive summary in your paper provides quite a long list of our key achievements and marks progress against the strategy. Now, we don't propose to go through each of those things, but we would like to focus particularly, I think, on 3 areas, because we feel they sort of highlight the way we try and work to deliver initiatives and improvements. What we always try to aim to do is obviously to improve services and outcomes and patient experience. We've also been trying over the last year to improve resilience in primary care. So that might be through the provision of investment, and you'll see there's been a significant investment in our access schemes, which Rebecca's going to talk about, but also wider things in relation to training and education, and linking practices to other local practices within our localities and also other local partners. We've done quite a lot of work through our localities, really, to try and have lots of speakers coming to our locality meetings so that the practice leads can really get a feel for what's going on in their localities, and also for us in primary care to share our information back. So, for example, we've had speakers from the Children's Safeguarding Board, we've had local counsellors come, and we've also been on outings to the Dementia Hub and also to some of the services at the Nelson to really try and raise awareness amongst all the practices about all the good things that are actually available to them and their patients. And then probably the third strong point really is that we've tried to increase membership engagement, and you'll see that when we speak about the practice variation work stream. So we've really engaged with our practices and tried to listen and take ideas from them and use those ideas both from practices and also patients to shape our work. So the 3 areas we're going to focus on is access, which Rebecca's going to speak about in a moment, and then I'm just going to very briefly talk about the practice variation work stream and the PMS review. So over to Rebecca.
Thank you, Karen. So my name's Rebecca. I'm part of the primary care team in Merton, so I really work on a local level with practices about driving change through our with our clinicians jointly. So essentially, there's a national ask to address access into general practice, but our plans really do respond to local patient feedback, and that's kind of where we moved forward to with our planning. At the last governing body, we spoke about our plans to deliver 3 schemes. This was around a local incentive scheme, the movement to 2 new GP access hubs in Merton, and then a quality improvement scheme. I'm really here to report on actually the evidence of delivery of these schemes and the response of actually investing over £1 million worth of into practices to actually improve this access. So I'm pleased to say that for the first initiative, which is the Improving Access scheme, all 23 practices are participating in the scheme, which essentially delivers more appointments during core hours and extended hours. In summary, that's about 3,700 extra appointments per month. Moving on to the GP access hubs in the east and the west of Merton, essentially that offers approximately 1,460 appointments per month. So if you total them together, you're looking at about 5,000 extra appointments per month, to keep it into context for you. So the third scheme is the quality scheme. 2 seconds. Essentially, this scheme focuses on patient experience and aims to help vulnerable patients gain better access to primary care services. This funded piece of work for practices consists of 4 modules aimed at upskilling frontline staff through telephony improvement. A second is around focusing on access for children, and a practice-based campaign for making sure that patients are aware of what services they can access, and also focusing on experience for carers and ensuring that registration for vulnerable groups such as migrants and the homeless are aware of how to access their appointments. I'd also like to pick up on a statistic in relation to the hubs, bouncing back here. Utilisation across the hubs we're very, very impressed with. So from April, we were starting off at about 47%. We're moving through in July to 74%, and I'm pleased to report that an update on the report in front of you, we've increased utilisation up to about 87%. Of course, utilisation can't really speak for itself unless you're asking patients what that actually means to them. So we've been making sure that we've been capturing patient feedback as well. I'm also pleased to report that about over 90% of patients demonstrate that their ease of booking is either easy or very easy. And over 95% of patients recommend the Access Hubs to their friends and family. So in summary, I think for us, creating change, it's about asking patients what they want and actually delivering on the floor changes. So I'm really pleased to report of all these statistics to actually represent the on-the-ground delivery. Happy to answer any questions.
Want to do questions now or at the very end? I'm happy.
Why don't you keep going through to the end of the report, and then we'll take the questions in one go.
Okay, so the next area we want to highlight really is our practice variation work stream. We're aware when we look at all sorts of data across primary care that there's actually quite a lot of variation between practices, even actually practices that are near neighbours. Now, obviously some of that can be explained by different disease burdens. For instance, one practice may have a lot more diabetic patients than another, but even if you allow for that, there's still quite significant differences in some areas. So the two areas that we've focused on in our practice variation visits have been firstly referral rates by GPs to secondary care, and also the utilisation of pathology testing. So what we've done, we've actually visited all 23 of our practices on 2 separate occasions over the last year, and each time we've gone out, we've taken a pack of data that's bespoke to that practice, but also to set their data within the context of other Merton practices. So it's a sort of peer review, and we've really taken a learning approach to it. We've not gone out and said, you know, you must cut referrals in this specialty. We've just presented the data and actually listened to practices and shared quite a lot of good practice across to other practices. What we found quite significantly when we went out the first time was that there was quite a lot of ignorance about all the local services that were available, particularly the Tier 3 Diabetes Community Service. So a lot of patients were unnecessarily being referred into secondary care when they could be seen much closer to home in their local area. So part of our work was really just to promote all the services, and as I mentioned earlier, we went to visit some of the services as well to raise awareness. And we also identified some practices were feeling that their locum doctors or their part-time doctors may be less well supported. So we asked them to set up actual peer review in-house schemes so that if doctors were not sure about whether a patient needed a referral, they could discuss them with a colleague that may know the answer. And we also produced a locum toolkit that the practices could actually make bespoke to their practice so that any locum coming in could have the information about all the key local services like the diabetes service, safeguarding, etc. So we saw that really as a quality improvement exercise, but actually it did deliver quite a significant financial saving in 16-17. We found that first referrals dropped quite significantly, not only just at the beginning, but the behaviour change has been sustained for well over a year. So that was a secondary benefit. The second round, as I said, we focused on pathology testing. We provided clinical guidelines for 4 common high-volume tests and asked practices to look to make sure they were following the most up-to-date guidelines, also to make sure that there wasn't duplication of testing. We enabled practices to be able to look up easily results that might have been taken at the hospital, so a patient wouldn't then have the same thing done the following month. And we went out to do that quite late in the year, about this time last year, in fact, and that delivered a saving of 60,000 at the end of 15-16. And to date, 17-18, we've got a drop in total cost of 171k. So that obviously, hopefully, has improved quality because patients are getting their tests in line with guidelines. But we're also seeing a financial saving, which I'm sure Neil's happy about, hopefully. Moving on, the final thing really was the review of the GP contract, the PMS contract that all our practices hold in Merton. This process was mandated by NHSE and devolved locally, and we worked very closely with Marek and our local LMC, and we had a really good experience of the process. It was clinically led, and we had some really good, robust discussions, both CCG clinicians and also LMC clinicians as well. And we believe that we've come up with a set of specifications which should deliver significant benefits when the contract starts in April 2017. I won't go through all of them, but they are in your paper. And we wanted to provide a broad spread. We wanted some transformational things, also some access things, and things around prevention. So we think we've hopefully captured a lot of good areas. To date, 15 of our 23 practices have signed up to the new contract, but we're still within the reading period. So, and it seems to have been quite well received. So I'm not going to go into detail about any of the other things. Really, just to say that we think we've achieved quite a lot. We're not complacent, however. We're now really switching our focus onto perhaps developing our access model a little bit further. For instance, we've got routine appointments, telephone appointments, and possibly online appointments coming soon via the hub. We're also piloting direct booking, so from A&E and from 111 into the hubs as well. So we won't drop off access. We won't drop the ball on that. We're hoping to develop that further. But we're also, I think, going to be focusing more on some of the things that have been mentioned earlier around the integrated working and primary care at scale. So we'll report back next time in a few months on that, hopefully. Thank you.
Thank you very much, Karen. So, stunned silence, because actually, you know, the scale of progress is really significant. I think it's the most progress we've ever seen in terms of improving general practice in the course of a year.
Thank you.
Certainly in the time I've been a GP, so well done. Shall I open it up to other comments or questions from the board? Dagmar.
Yeah, I want to iterate as well that I actually think you hear always the message in the news, you know, primary care is on its knees and the day-to-day pressure is certainly relentless. So having the headspace and the willingness and the tenacity to see this through, I think we sometimes have to actually say, well done, not just always picking on the problems. So I think wholeheartedly I would support that from a local authority point of view. The other plea is, and I've said it here before, that it's around the comms piece. People simply are not aware of some of the good stuff. And if I hear 5,000 extra appointments a month, you know, that's massive. That is absolutely massive. And the accessibility of the access hubs, we have heard, sort of East Merton with a particular need, you know, that's Saturdays and Sundays, 8 to 8. That's actually really a super service. So people out there, often colleagues, when I tell them, they say, really? Why haven't I heard? So I think we could do a bit more comms around it.
Thank you, Dagmar. Marek.
Thank you, Chair. I just wanted to reiterate what Karen had said about the PMS review. It was indeed a very constructive and good process. It should be taken into account that Merton CCG and practices in Merton were the first in London to actually have the PMS review approved centrally by the appropriate bodies. That required a huge amount of work, a lot of goodwill, and a collaborative approach. And I think that this CCG is in fact remarkable for that. There are areas in London where they are at loggerheads with one another and finding it very, very difficult to gain any progress. So whatever discussions we may have had, and some of them were indeed quite robust, the bottom line is that the approach here has been entirely collaborative and very much focused on how to improve care for patients at the same time as not destabilising general practice. So for that, I do want to publicly state my thanks to the CCG for that. My thanks back to me was well deserved. So.
Thank you.
No, I think it's Marek. Your iPad's interfering with the that's it.
Claire.
I think Dagmar stole exactly what I was going to say, but I completely agree. I think this is a comm story we really should be getting out and getting out to the public, because there is so much historical sense of not being able to get an appointment, and actually, as you say, 5,000 extra a month is absolutely to be celebrated. I think there's a tremendous amount of work's gone on. I'm really impressed with this. We were at the Primary Care Commissioning this morning, and I said exactly that. But what I'm interested in is where are we going to take this information? Will you be going back to the patient engagement group and talking to them about it? How can we communicate it to the patient participation groups that this is the stuff that's going on? They may not notice huge differences, but it will have an impact.
Yes, I think we've got the message today from the 2 primary care papers that we definitely need to communicate more. For both of them, it's an opportunity today to come here for the first time in quite a long time to talk about what we've done. Absolutely, we can't rest on our laurels, and I reflect back to the public meeting at the end of January around the Wilson, and we talked about access hubs delivering about an extra 4,000 appointments, and now we're doing an extra 5,000, so we're doing more than we actually said we would do. But you're right, Claire, until today we haven't actually said that anywhere. So we will be, I think, very much getting on the front foot with the comms now.
Well done. I shall move us on now to, thank you, Rebecca. I'll move us on to section 11, which is quality and performance. So we've got the summarised minutes of the Clinical Quality Committee from both September and November, which are for note and possibly discussion. Claire, did you want to was there anything you wanted particularly to pull out of those?
I think most of the performance issues John will be looking at. It's all pretty much there in the minutes. I think the 2 bits I'd pick out were the session we had with South West London and St George's and CLCH on children's services, and particularly in transition to adult services, and just the real difficulties that there are for so many children. And I think that all comes into the mental health work that we're talking about doing into the future. So very much cited on that. And the other bit was, I think, around the St George's Clinical Harms Group review after 6 months, and the concerns that we still had and continue to have about some of what has been happening within St George's of late. I mean, that's on, I can't see what page number it is, but page 6. We've highlighted the items there, so I don't think there's much more I can say.
So just following on from Claire and the clinical harm group, we took, I think, for the second time. The first time a paper or some information had gone to the Quality Committee was quite early in the year. So we took some assurance around the current process, but I think going forward we probably need to take a bit more of an in-depth paper, and we agreed that. So it wasn't that that we were concerned about it, it was that we weren't sure that we brought enough assurance, because we deal with that quite a bit through ones with CCG, but we need to share that wider.
Are there any other questions or comments relating to the minutes? Let's go on to the assurance report. John.
Thank you. The report this month is in a new format, so for the first time we are beginning to try and make clear against each of the indicators that we look at, either monthly, quarterly or annually, where there are exceptions to delivering against the national or local standards. We are trying to summarise on a page the digested view of initially what that indicator is, what it is we're measuring, where our current performance is against delivery of that indicator, what's causing the underperformance and what we're doing about it. And we're trying to provide in the tables and charts some context in terms of the legacy of delivery and what that looks like increasingly, both in terms of the CCG absolute performance, but also the comparison to the London average and to our previously reported position. The intention of all of these changes is to try and provide a report that offers a greater degree of detail against each of the indicators and more precision against our relative performance against them. And these areas of underperformance that are called out in the report are discussed at the Clinical Quality Committee and also are worked on relentlessly between those meetings in the various forums and committees and escalation meetings. So we talked already, for example, in James's introduction about the RTT regulator meeting with NHS Improvement, NHS England, where we look in some considerable detail of the progress of the recovery plan for waiting times at St George's. But there are similar meetings that take place on a frequent basis with regard to mental health services, with regard to A&E services. So between the snapshot updates at both the Clinical Quality Committee and also monthly at the board, there is a considerable amount of work that takes place in the intervening period to try and move forward with some of these mitigating actions, and where, in spite of mitigating actions, we still have residual concerns to try and further mitigate what those concerns are. So hopefully the new format, several people have looked at this when we were developing it, but hopefully it's a step forward in terms of clarity of our relative performance as a CCG. Of course, against the 25 or so indicators we report on monthly, a huge proportion of that is affected by the relative performance of the various providers we commission. So across South West London and wider, there is a differential impact on CCG reporting of, for example, the waiting times at St George's. So partly that depends on how many patients would be referred into that trust, and also there is a degree of random fluctuation in terms of the relative impact of some of those performance issues on our cohorts of patients. So what this report does, in the context of some of those problems, it gives a lens for the Merton population that we commission services for. Calling out then the highlights in terms of the content of the report. So I won't pick up IAPT here, there's a separate paper, but there is an ongoing problem with our access to psychological therapy services that we'll talk about in a moment. The other key areas of focus that we are continuing to work on are the referral to treatment times with St George's. Across our other providers, because St George's continues not to report nationally its performance, so it's excluded from the national report, we do have some ongoing issues with Epsom and St Helier following some scheduling of clinics that occurred earlier in the year related to some IT problems. There is a plan in place to move that forward, and we are seeing signs of recovery, albeit that there's some slippage in the timetable. With St George's, where when they do validate the current waiting lists and move into a position where they can report performance, we know that there's going to be some significant issues with overall waiting times. So there's a whole programme of work going on at the moment to further validate where waiting lists have some data in that we can't trust at the moment, subject to further validation to make sure there's no data anomalies remaining. We will finally get a picture of what the total waiting list is, and set against that we can then more clearly understand what the trust can do on a weekly or monthly basis, what their run rate is, any further additions they can do to increase that run rate, and then what gap that leaves, and where that gap could be further treated. So we know that we've done some work in the past with looking to transfer some care to other NHS providers. We've had a fairly small contract with a private sector provider around dermatology referrals, and we've also worked very hard with our GP colleagues around capacity alerts on the electronic referral system to make it clear that for some specialties a wait at St George's would be significantly longer than for the same clinic at other South West London trusts. So we continue to work through a fairly lengthy but very detailed recovery plan, and we have our next meeting with regulators tomorrow for the next of the fortnightly updates. Moving on to A&E, there's also a paper which we'll come on to shortly around winter planning, but in terms of A&E, the Trust at St George's have been performing around about 90% across much of the last 6 or 7 months. The relative performance for Merton patients has been slightly less than that, and recently we've begun dipping below 90%. There is again a recovery plan in place, and there's a winter plan in place which is anticipating the rise in attendance and admissions that will take place over the coldest part of the winter from about now till March. And again, we continue with the Trust to look at other opportunities to have fewer people attend A&E where those conditions they're presenting with could be better cared for in primary care or by community pharmacy or by any other means. There is, as we know, a proportion of people who would get better care by seeking those alternative pathways, and we continue to work with them through a front door streaming to ensure they can be better served in other settings if that is suitable for their condition. In terms of the other side of the hospital, in terms of people who've been admitted and are seeking discharge, we've increased our focus on addressing any problems with delayed transfers of care, delayed discharges, working very closely with our social care colleagues and our CCG colleagues to ensure that people aren't taking up further time in the hospital again when they could be better placed either back in their own home or in other care settings. We've included a paper on the recovery rate for access to psychological therapies. This is a much narrower problem than the wider access problem we'll come on to shortly. So a national standard is that 50% of people undergoing psychological therapy treatment should reach recovery. The performance of the Merton service has been around 50% across the life of this contract, but has been dipping below 50% in recent months. So again, we're working with the provider to make sure that all meaningful opportunity is put in place, and if people don't recover from the course of cognitive behaviour therapy treatment or mood styles or whatever mode of treatment they have under the IAP service, that they are reviewed before they're discharged to see if they'd be suitable for another method of delivery of that service or stepping up to more intensive service before they're discharged without recovery. But I think a much more contained problem than the paper will come on to shortly. Some minor performance issues, relatively speaking, around two of our cancer targets where we've missed the indicator in the most recent reported month of August by a small number of patients. Again, with cancer services, we track performance very carefully, and we've recently had an issue with patients who were on 2-week pathways for St George's and issues around capacity, both administratively to book and manage those appointments and to see those patients. Thankfully, they've been fully resolved, and the issues that remain are relatively contained. In terms of delayed transfers of care, we've set out our current position. It's measured both in terms of overall and then social care and NHS delays. Again, the paper sets out where we are in relation to that. There are some data issues with the July and August data that has been resubmitted because of some errors, and that will be updated in due course to give a much more positive position for July and August. So I think summarising, in terms of our overall concerns, I think there are three real areas of performance that we're doing considerable work on. There's the access to the IAP service. There is ensuring we've got as resilient as possible A&E department at St George's and wider winter urgent care service across the whole of Merton, going into the most challenging part of the year. And finally, the waiting times issues at George's. I think we now have done significant amounts of the validation. There is further validation ongoing, and that is ahead of schedule. And at the conclusion of that final validation work, we'll be left with much greater clarity. Clarity is emerging already, but we'll be left with final clarity on the real groups of patients that do need to be seen, what St George's can do within its own capacity, any further residual increases it can offer, and then what else we can offer to get those patients treated as quickly as possible.
Thank you, John. I like the format in that I think it's clearer than anything we've seen before. There was one thing that you hadn't particularly talked to that seems to me quite critical, which is the e-referral service and our utilisation amongst our GPs of e-referrals, which is 16% against a target of 80% and a London average of 40%. So that is really low. And when we talk about the issues with referral to treatment times, one of the problems is if you don't use the e-referral system, you don't necessarily, you're not necessarily aware of the waiting times for a first appointment, but also the indicative time it will take until you get treated, which does show up on the e-referral system. So it seems like, although whether GPs use an e-referral or a paper referral probably doesn't seem particularly important, in this context it is actually quite critical. So do you have a view on why, I know utilisation rates have been low for quite some time, do you have any view on why that might be and what we might be able to do about it?
I do. I think that there's a couple of things at play. I think that there's been a very high error rate in the past. So GPs who have been using e-referral, there's been a very high instance where they've tried to book a patient into a clinic and that booking hasn't transacted for various technical reasons. And I think probably if you try and do that a couple of times and it doesn't work, you probably don't continue trying to do that. So I think for some GP colleagues in Merton and elsewhere, that's been a factor. I think St George's, taking them as an example, have found it difficult in the context of the overall waiting times problems they're facing to make available through their electronic system an abundance of capacity against all their clinic types. And I think they're dealing with a very complicated validation issue that's been seen over the last 18 months or so, and their capability and capacity to offer a full ERS booking service is somewhat affected by that. And I think also that there's a technical element. I think for some of the systems aren't fully updated with the latest software, which allows a minority, but some GPs to transact electronic referrals. In terms of the way forward, there is a plan that is rapidly emerging, or two plans, a commissioner-led plan which looks at working with GPs to significantly increase utilisation, but knitted together with that, a provider plan which looks at significantly reducing the error rates where you try and transact a booking for an appointment and it doesn't work, and making available the whole suite of clinics on the electronic referral system. And I think what we're doing at the moment is trying to synchronise when those two plans happen, because there's no point us promoting very actively with GPs the use of this service when there are still some errors that are being corrected. So we've got a milestone plan that James will outline to NHS England, NHS Improvement tomorrow, and we'll rapidly move to full project plan over the next month or so, and then delivery in 2018.
Thank you. Any other questions or comments? Julie?
Just with regard to IAPT, I know you've done a paper, but I know that you also meet regularly, and I just, from the information which you've given, I haven't got a feel of how you feel it's going, if it's improved. I know what the statistics say, but do you feel that it's improving in the right direction and it's sustainable?
In terms of IAPT access rates.
Do you want to hold that thought until we come on to the IAPT performance paper?
Yeah, absolutely.
And then,
So if I outline the paper, then I'll respond to
give
that
us
question.
a view when you present the paper.
Yeah.
Just to avoid repeating the same thing. I think you're going to take us through the IAPT performance separately, are you? You've got a separate paper on it. Yeah.
Should I do that now? So, in terms of, I'm okay to move on. Sorry, Chair.
Well, before you do, are there any issues people have or questions relating to things other than IAPT that you'd like to raise? Because I think once we go on to the IAPT paper, that will focus our minds on that. Okay. So I think the first question before we move on is, are we happy to approve the assurance report as a board? Yes? Good. Okay, so let's then go on and specifically focus on IAPT.
Okay, thank you. National standard for IAPT in 17-18 is that 4.2% per quarter, 16.8% over the course of the year of people who have depression and anxiety should receive psychological therapy services with the recovery rate at least 50%. At the beginning of the year, Merton CCG commissioned Ad Action as our IAP provider to deliver 3.75% per quarter, so 15% across the year. So I'd set a plan which was slightly below what the national requirement was. That may have been something of a defensible position had performance been in line with that 15%. But as the validated monthly performance shows on page 3 of my paper, that hasn't been delivered. In fact, over the course of April to September, the first half of the year, about half, give or take, of the number of people that needed to enter treatment were entering treatment across those months. And for some of those months, the number of referrals from GPs or from self-referrals were below the number needed to achieve the 3.75. So during that time period, it was only July and August where there were more referrals, or referrals exceeded 318. So more referrals than the minimum number to reach the access target. So that's the first issue, really. Over the first part of the year, number of referrals going into the service were below what was needed, given that there is some attrition rate. So people who self-refer tend to be more motivated. Sometimes people who are referred by GP subsequently reflect on that referral and decide not to take up the service. And indeed, some people who are motivated to self-refer subsequently decide that it's not for them. So certainly the referral rate needed to exceed the minimum for the 3.75. The second issue then is the capacity issue within the service. So over the course of this year, the service has carried a number of vacancies, and that's led to some waiting times that have been within the national waiting times of 6 and 18 weeks, but have still led to some delays. Many IAP services across the country will use seminars, so a number of people will go through a sort of guided self-help mood therapy seminar or use online provision, and they're very efficient ways of delivering IAPT, and absolutely you need the patient choice to be very overt and patients to choose if they would like to go through that model of IAPT. But Ad Action have predominantly used a one-to-one type model, so compounding their recruitment issues, they've generated some longer waits. And also in comparison to other services, the attrition rate, which I've already mentioned, has been higher than we would have expected from the service. So again, of those people who've referred, a number of them have dropped out either before they've had their first assessment and treatment, or during the, on average, people have 8 sessions of IAP, so at some point during those 8 sessions, people have dropped out. An improvement plan has been put together by the provider, and that looks predominantly at increasing the number of referrals and mitigating the attrition rate once people are referred into the service. We have obviously been profoundly concerned about this as a performance issue, and certainly since August, September time, we've been running weekly, having weekly teleconferences with the provider to look at what the action plan is doing in terms of improving the position, in terms of increasing referrals, reducing attrition rate, and delivering against the target. We've also agreed with them that given the relatively low performance over the first part of the year, that we are now seeking performance above that initial plan of 3.75% per quarter. So for Q4, we're looking for 4.1%, and they've committed to that. And there's a couple of ways in which they are seeking to deliver that extra level of activity. So first of all, there were 5 vacancies within the service that have now been covered through various, through recruitment, through moving people from other parts of the service. So a big recruitment issue that IAP services in London and nationally face, Ad Action again had a particular problem with, and have now, just in the last week or so, recruited to the last of those 5 vacancies. They've also agreed to bring online another IAP provider, one that predominantly provides an online service. And again, we do very much recognise the patient choice, but the experience elsewhere tells us that there are a cohort of patients who do quite like the flexibility that an online IAP service offers them, so they can have that service on a weekend or late in the evening in a way that the traditional face-to-face, although they operate across an extended day, they certainly don't operate at 10 or 11 o'clock at night, and for some patients that's an active choice. So these actions predominantly mobilise over the next week or two. Some of them, like the recruitment's already happened. If you turn to page 5, it then sets out what that looks like from October through to the end of March. So
I think it's page 3 in our packs.
Oh, okay. Apologies. So what that does, it sets out the target number across the top line that need to enter treatment over each of those months. And then we've got 1 month of actuals for the month of October. And my apologies, there's an error on the second line. So the number that says 339 should actually be 296. That was my error using weekly or monthly validated data. So the weekly data gave a slightly higher figure because it included a few days in November. So that gave the provider an 86% compliance against the plan that they'd set. And within the next day or two, we'll get the November actual position, again, to see how close they are to the 240. So again, a slightly lower position for November, partly because they've got some backlog here, so people who've already gone into the service who need to be treated. So we're mindful both of increasing the number of first treatments, but not growing a backlog of people who are some way through the 8 or so sessions that people would have on average. So the current average wait time to first treatment, 2.9 weeks, but then slightly more concerning, the average wait to second and subsequent treatment, 7.1 weeks. So we don't want to grow a backlog to the detriment of bringing new people in. So that's why there's a sort of U shape to that overall top line trajectory. So to bring it together, in terms of our scrutiny and the provider's plan, we think that with the additional capacity from the provider that will come alongside AdAction, with the recruitment they've done, and with a greater focus on more efficient ways of working, again subject to patient choice, they will have sufficient capacity to deliver the amount of therapy over the remaining 3.5, 4 months of the year to get us into a much stronger position. I think our concerns have been that for a number of months the capacity just hasn't been available, and the ways of working have exacerbated that in a way that other providers it perhaps would have been somewhat mitigated by groups and by a big online presence. But we are certainly tracking weekly and asking for evidence of each action, of delivery of each action. There's 15 or so actions in the action plan, and each one of them has been scrutinised to some degree. And we're also carrying on with marketing. There's a new marketing campaign about to launch. There's an online campaign which will continue, but we're going to use some bus stop type advertising, which, although quite old-fashioned, I'm told is quite effective. And we know that the Christmas period, fewer people access psychological therapy services, which gives us this opportunity to start working with the backlog of patients who are already within the service. And then come January, it's the steeper rise over the last 3 months of the year to get back to a reasonable position for year end.
Thank you. Let me just check first. Did that answer your question, Julie? Well, okay. So what bit of your question would you like to explore a little bit more?
I guess I'm assured by your weekly scrutiny. I guess that would be the. My concern is that we have got 7. We've got. Sorry if I put my glasses on. 7. Is it 7 weeks backlog? So, and we're getting more people in the system. I know we've got more people, but we're going to see a spike. Is that?
So absolutely, that's an entirely legitimate concern about the relative balance between taking new people in while looking after and treating those that are already within your service. If you grow a backlog, that means the next your treatment for your second and subsequent course of treatment is 7 weeks. I think we absolutely recognise that is the balance, and what the weekly conversations helps to do is look at how the provider have deployed its resource in the previous week, how many new patients it's taken on, how many people have completed a course of treatment. I think it's probably fair to say it's highly unusual for a commissioning organisation to have a weekly conversation about demand and capacity with a provider. I think they found it a very difficult contract to service, the Merton IAP contract, for a variety of reasons, particularly the workforce issues that were there at the beginning of the contract.
I think there's a number of further questions. So I had Steve, Andrew and Dagmar. Should we just go along the line?
Sorry, you might have asked this, Julia, while I was temporarily out of the room, but obviously it's something we need to do an awful lot better in, and it's good to see October performance, even with your adjustment, has been better. But you've mentioned a number of things that the recovery is contingent upon, and I just wanted a sense of what you think poses the greatest risk, and whether there are additional mitigations that you've put in place or the provider can put in place against what you consider to be the biggest risk about sustaining that recovery trajectory.
I think the biggest risk is the capacity over the remainder of the year, so ensuring that the capacity from Ad Action, the recruitment they've recently done, that those people very rapidly come up to being able to have a full caseload. There'll be a short induction period for some of those people as they move from previous employers, etc., and get used to the systems and processes. And also bringing alongside the new online provider of IAPT and making sure that we, as rapidly as possible, identify and offer to cohorts of patients who may benefit from that, and do all that very quickly. I think one of my concerns with the provider is its ability to act as quickly as we'd like, and in spite of our very best efforts to try and push forward with pace on every aspect of the recovery plan, I think sometimes it builds in extra days of delay that we'd prefer weren't there.
So is there anything additional we can do to mitigate that risk?
I think we've probably, as far as any commissioning organisation, we've got our mental health commissioner, our director of commissioning, myself, and one of my performance managers looking at this on a very regular basis. I think it calls into question, to some extent, we're having to do this with a provider, and clearly that's not sustainable forever. So what we hope is that the improvements will happen over the last quarter of the year, and then crucially be sustained. So you exit the year with a 4.1% rate that you sustain going forward, in which case we can reduce resource managing this contract.
John, maybe another way of putting the question is, it looks like we've deployed Plan B, which is online therapy. What's Plan C?
So if Ad Action don't mobilise the additional provision through the third-party provider, we will take independent steps to get that from another route. That's Plan C.
Andrew?
Yes, it's probably be partly already covered, but I'm not really very clear how confident you are that you can actually achieve a step change. I mean, it's not just a case of monitoring and putting pressure on the provider, is it? I mean, to get a step change of this kind and that scale is really quite considerable. And I just wonder what your confidence level is that you can actually do that.
I think my confidence is moderate. I think the opportunity is not just in having 5 more members of staff, it's using them more efficiently. There are IAP services in London that default almost everybody into a group or seminar setting and get very good recovery rates and perhaps get some pushback from a patient choice point of view. I think this service has offered by default one-to-ones to everybody, and that's caused a therapist can see 5-6 patients over the course of a day, but you could have 10 people in one group, and groups would run for 90 minutes, 2 hours, so that there is a huge step change in efficiency of a service depending on the model it uses. And likewise, I think we've had less than a dozen people use an online platform with this provider. There is an online option in very, very small use. So again, much more proactive use of an online offer, which again is far more efficient way of working. So I think my degree of confidence is moderate, but that's where that step change will be delivered. It's ways of working, I think, not another group of people to join the service.
So before I bring Dagmar in, if levels of confidence are only moderate, I guess it might be helpful to understand, maybe for outside of this meeting, but a little bit more clearly, at what point we make the decision to move to Plan C. So what the decision-making criteria and timeline and process will be around that.
Yeah.
Well, I mean, I think what I would say is that John and I are discussing this very regularly in terms of the feedback on the discussions with Action. I had an escalation meeting with Action a few weeks ago, which kind of prompted this latest round of planning, and they came forward at that point with the proposal to bring in IESO. It was something that we were looking at separately anyway, and we were having conversations with other nearby organisations about what capacity and support they could bring in. Several of them mentioned IESO as being that option. So I think that you know, for me, it's about that close contact with the provider. It's about being clear that they are taking the steps to mobilise the additional capacity, and at the point where if we got to a point where we could see that they weren't, and we didn't have positive assurance around that, we would do that. We would do that without recourse back to the board, because I think, frankly, that would be something that we would just make a decision to go and do, because we don't really have the time now. We need to just be right on top of it.
Okay, Dagmar.
It's in a similar vein, but stepping back a little bit, because I have sort of déjà vus of having really similar discussions for quite a while now, which begs the question whether are we hitting the right service model? And I know it's a very prescribed service, and it's sort of almost nationally blueprinted, and it might not be the right fit, because there is things that just aren't fitting together. So there's a need out there, but the provider and the need don't seem completely congruent. And so earlier rather than later, sort of obviously trying to see what can we through to purely contractual means to squeeze, but do we need to at the same time step back and review the model with the community and all the different screams for help and need on mental health out there, so that we possibly think of overall, can we get a better match?
It's a fair challenge. There's different ways of commissioning IAP services. The model in Wandsworth is different, the model in Sutton is different, the model in Surrey is different. Surrey have a much more open specification, and they allow effectively an any qualified provider approach, which means that you get a little bit more innovation in the market in terms of the ways of approaching people. Wandsworth use a sort of multimodality model using South West London and St George's, and then using a number of subcontracted providers. We have an opportunity to reprocure this service for the back end of next year, and I would expect addressing some of those issues to be exactly what we do as part of any reprocurement and redesign exercise. I think there's a lot of lessons we can learn from where we've ended up at the current time, but notwithstanding, we have to mitigate the issues that we have. The final thing I would say on this is that there is work going on across Healthy London partnerships on digital mental wellbeing, including targeted interventions online to get people into cognitive behavioural therapy, including links to local IAP services. So this is basically, looking at people who are looking for certain things online that may be an early indicator of anxiety and depression, and trying to get them into CBT-based services either through IAPT or other routes. And I think what's really important is that we link in with models like that, because I think having a sort of a GP-referred service or even a self-referred service that there's a poster up at a train station, the world has moved on, and other sectors are much better at targeting people who may be well served by something than we are, and we need to start using those sorts of techniques.
Okay, I'm going to move us on. I think what would maybe be helpful would be for us to hear back in January as to where we're at, because there's obviously, you can hear there's a lot of concern, and I mean, it sounds like you're giving it a huge amount of attention and effort, which is reassuring, but clearly it remains quite a vulnerable area for us. So I think hearing back at the next board meeting would be quite important.
Yeah, absolutely.
I'm aware that I've committed to allow time for questions at the end, so I want to make sure we've got 2 more items to cover. So if we can try and move through those quite quickly. We've got winter planning and the safeguarding annual report. So let's do winter planning next. I think we should take it that people have read it, so we won't go through the report in much detail, but rather devote a bit more time to questions and challenge. But Sarah, did you just want to give an introduction to this item?
So apologies to my colleagues because I didn't know I was going to do this, but I thought it was worth, before we go into the detail of the local, just giving a bit of an overview to the governing body about the level of oversight that we have of winter, both nationally at London level and a South West London level and a local level. So it's obviously a very high priority for the NHS across the board. It's really important for us that we deliver services safely across the winter period. There is national oversight of what we are doing around planning for winter that we report regularly on. We have now got a director for winter in London who has been jointly appointed by the regulators to have oversight of what we are doing and to help us to predict when things might not be going as well as they should be going, and to make sure that we have plans in place to deal with any future problems based on that prediction. We also have urgent and emergency care delivery boards at a local level, and we have one for South West London and then one for each of our systems, and those are whole system groups that have oversight of the emergency and urgent care pathway, and they develop the plans for winter along with all of their other plans around urgent and emergency care. So, and we regularly report at South West London level, at an individual system and an individual organisational level on all of the plans that we have around winter. So I just wanted to give you a kind of understanding of the level of assurance that we have from both our regulators and from internally within our system around this, and what an important priority it is for us to make sure that we deliver on this before I hand it over to my colleague.
Is it you, John, or you, Andy, who are taking the lead on this? John?
Yeah, I'll start, but conscious of the time, just very briefly, I'll assume colleagues have read the paper. So winter planning for 17-18 very much reflects lessons learned, reflects trends and issues that we experienced last year. It calls out the considerable winter readiness assurance process that NHS England asked us to undertake, which is effectively a self-assessment process against a whole range of things. The ambers and reds that are contained in the paper are the areas that we weren't able to assure ourselves as green. So this is actually, although it perhaps looks like a fairly long list, is actually, as a subset, a very, very short list. And we've got ongoing work this week and last week to try and move all those ambers to green and those reds to at least amber, if not green. There's a lot of detail behind each of those descriptions, but working very hard to move those forward. The demand and capacity planning we look at on a daily basis from mid-December through to middle of January to make sure that our predictions around GP access, which Andy will come on to, and access to acute services, particularly at George's, are adequate, and that we do have the right amount of staff available both across the winter, the Christmas, New Year bank holidays, and then in those very pressured first few weeks of January. And finally, the escalation framework that we use. So we already have a daily call where we look at the relative pressures on the system. We are adding to that with a weekly call looking at delayed transfers. And often with these calls, it's about getting the right group of people. So you can have actually quite a small group of people, but those who are empowered to make decisions. So this morning, for example, I joined a call with the Director of Adult Social Care for Merton as part of the weekly detox call, making some very pragmatic decisions about how we ensure we have as few detox as possible to give ourselves the best possible bed balance going into a winter weekend, and we'll do that to an even greater extent, I think, as we approach the bank holidays in 3 or 4 weeks' time. So I think to echo Sarah's point that there's a considerable resource focused on as far as you can possibly plan to mitigate those increases in demand over the winter. We know that George's are already experiencing some record days, particularly on Mondays, where people have had some sort of problem over the weekend of waited till Monday, and we know that the winter is considerably busier. So all of these plans look to mitigate that.
Just picking up a couple of issues within the primary care. So you see the amber, the second one down, NHS 111 primary care. So this is actually a technical issue with EMIS. So this is around NHS 111 or in fact actually ED, which referenced later, been able to book directly into either our 2 access hubs or general practice slots that have been made available. All the software from our side is ready to go. It's simply a technical glitch that's been discovered in East London before the whole service can go live across London. So that's not necessarily something in our control, but obviously something we're very mindful of and making sure we've got everything ready to go when that's up and running. And just there's a minor point in terms of the interpretation on the resilience. So it says an extra 6,000 across Wandsworth and Merton per month. That's actually an incorrect figure because we've got an extra 5,000 as we talked about in Merton. The 1,000 references the Wandsworth. We've got 3 hubs in Wandsworth, not the GP practice appointment. So that's just something I can clarify for accuracy after this as well. But we have had to make sure we've had very detailed checklists around every single GP practice, around opening hours, and also to ensure our 2 GP access hubs are open Christmas Day, Boxing Day, all the bank holidays. So it's very much business as usual, which I think is unlike anything I've ever experienced before in the winter. So it's clearly a top priority that's been dealt with like never before, I would suggest.
Okay, so shall I open it up for questions? Dagmar.
Yeah, can I just clarify there is another red one which says public health is responsible for sepsis sequence, and I don't quite recognise that. I'm sure there is an explanation and it got lost in translation. And while I've got the mic, from the public health point of view, the flu vaccination is one of the biggest things that we can do. So it's a plug again, particularly staff vaccination, and NHSE has been generous. So a lot of frontline staff in care homes and social care as well as in healthcare get the vaccinations reimbursed. We had big publicity throughout the local authority. We had vaccination sessions in the civic centre, but that we all take it back to our own constituencies to say vaccination is in our control.
So I think that's absolutely right. We've got a huge communications campaign in South West London this year. Vaccinations particularly focused on young children, as we know, as one of the priorities. We are measuring our staff in the CCG, which is unheard of, actually. The numbers of staff that we are encouraging all of our staff to have a flu vac, and our providers are doing very well, actually. I think some of them, I think Epsom St Helens is one of the top in the country, actually, for delivery of their flu vaccination. So all of our, and in fact, they're quite competitive about it, can I say that? You ask them, do you know your flu vaccination numbers? And they do, and they all want to be better than each other. So we're well over the 70% on the, I think, on all of our providers around flu vaccination so far, and there's still more to come. So I think that's very positive for us. Obviously, that doesn't negate all of the risk, but that's a good thing, and we need to keep that up. So absolutely.
Just to say, I will pick up the sequence sepsis question with you, because I've got a similar question. Okay. And then we have had a session in the CCG where we have vaccinated the staff that we could get to be vaccinated, but we did do that just a couple of weeks ago.
Any other questions before I move us on? So we're asked to note the winter planning report. Well done on that. Let's go on to 11.5, which is safeguarding annual reports, both children and adults. Julie, you're going to talk us through those.
I am. I don't think you're going to hear anything today that you haven't heard, because of course Merton always got quarterly reports around safeguarding to the actual governing body. So this is really just 2 summary reports, but they are deemed the annual reports. The first one is the Safeguarding Children report, and again there's a lot of information in both of these, and I am going to presume people have read them, but just to go through some of the highlights really. As CCGs, we have an accountability and assurance framework from NHS England, which tells us what we need to do around safeguarding, and it refers to a lot of legislation, but also the roles and responsibilities that we have. So we do have our required people in post that we need to have for safeguarding. That's our designated doctors and nurses, We have an exec lead, we have our effective policies in place, and we have to have arrangements in place for ensuring that we safeguard children and young people, and we do that through our commissioning contracts as well with our commissioners. From the point of view there with our whether we're compliant with that, there's just one area that we're currently still, I suppose, struggling with in some respects. We were able last year to recruit to the named GP for safeguarding. So you could say within this time period that we did have someone in post. However, that post then became vacant, and we've been out to advert for that. So that closes today, and I know that we've so far got an application for that. So hopefully we will be able to fill that post again. Looking at the work that was done, or that was supposed to have been done over last year from the previous aspirations, most of the functions and responses, most of the plans of what we said we would do was fulfilled and carried out. One of them, as I say, was the named GP, which I've just explained. The other was making sure that we had a leaflet for children around safeguarding so that they understood what safeguarding was and how they could access services themselves if they needed to be. That's still not being quite completed, but that is about to be, and I would like to think by the next time we go to the Safeguarding Committee that has now been sorted. Within the time period, we had a deep dive with NHS England where they look at all of our processes, procedures, and we have to give them assurance around ourselves, but also around our providers. And we were rated as compliant with what we needed to do. I think every CCG had some learning from that, and some wrote action plans and presented them to NHS England, but there wasn't anything that was of a great concern to them in regards to Merton. There's quite a bit of detail in the report which talks about the performance in the trusts. Bearing in mind this is last year's report, it's probably not worth looking and thinking that that's where we are today, because we've had 2 quarterly reports since then that have moved us on quite a bit. But it would be fair to say that most organisations have improved greatly on the reporting that they had. Some of the areas last year that were a concern were that the providers weren't reporting on safeguarding supervision, and all organisations have to make sure that they have supervision for the safeguarding staff. It's quite a stressful area to work in, so we now monitor that with all of the providers as well, and they've all got plans in place and they all report their levels of supervision to us when we get that information on a quarterly basis. We have got detail on training compliance as well, and as I say, that will have moved on from now, from what you see in the report. The Children Looked After service is briefly looked at actually in this report, and it would probably be worth saying that in future I think we'll either have a separate Children Looked After annual report, or at least have separate reports for that rather than it be combined. We do commission that through Sutton. Sutton CCG host it for us, but we do that with Epsom and St Helier for the initial health assessment, and with CLCH for the review health assessments that all children should have. There was definitely challenges around that performance over the year, and you will see that in the paper. And I think it's fair to say that we've put a lot of challenge back to them about how they're going to increase the initial health assessments that are supposed to take place within 20 days of a child being placed in a new placement, in a new home. We work quite closely on that with Sutton, and we do escalate those concerns to Sutton CCG, but they do manage that for us. CLCH are in a better position with their review health assessments than they used to be, so we're confident that those they will retain that performance, and we don't have any major issues with that at the moment. I think just to finish with the children's report, one of the things that we must do is we did review the arrangements around our safeguarding team in February, and we did have a review which looked at the 2 organisations, Merton and Wandsworth CCG teams working together. The teams do work together, but we mentioned earlier that we made a commitment that we would review how that was working and whether we've got enough capacity within that team. I don't know whether we do or we don't at the moment. There's nothing that's that's been highlighted to say that we don't have the right capacity, but there is lots of comments certainly, and I'm sure Dagmar will acknowledge from the local authority to say that the team is a bit stretched. So we are going to do a review around the capacity within the team, but we'll also extend that to looking at the roles that people are carrying out and whether what they're doing is what they should be doing or whether they're picking up areas that maybe doesn't sit within the CCG role. The other bit that we'll do is look at our policies across the two, so look at the policies across Merton and Wandsworth and make sure that they're aligned together, because we all follow the Pan-London procedures when we write policies for safeguarding, so really it would be beneficial if we had one policy. And then going a little bit further than that, we're working with our Alliance Director of Quality and Governance to look at whether we can do something a bit more broadly across the South West London itself and see as to whether we need to actually have, I suppose, the reporting mechanisms that we've got in place and whether we can combine them and streamline them a little bit. So because I've mentioned around the resource and the concern that people have, we do currently have that on the risk register, but I'm hoping that by January time we'll have some feedback from someone that's going to come and do that review around the resource that we've got. Julie, I know you sit on the safeguarding committee. I don't want to put you on the spot. I don't know whether you want to add anything. You were here all of last year when the report, what the time period that the report talks about.
Yeah, I think certainly I was very concerned, and I think Karen also and Claire around the arrangements when when the changes occurred. But I think obviously since you've been in post, there's been new staff and staff appointed too, so there is more people there than we originally thought. But I'm like you, I'm not sure that we still have what we need. But hopefully this report will give us what we need.
And I'm not saying we haven't got enough either. I haven't said that because I really need to review it and look at that.
Do you want me to chip in on that point, or
yeah,
do you want to open?
No, go on, chip in on that.
Just in terms of the capacity, so context-wise, obviously, it's quite tricky when you want to cover both boroughs because the context is very different. So Merton Borough has just had their Ofsted and they were solidly good with outstanding features. Particularly their safeguarding board is one of the 5 best in the country. And then you have got Wandsworth with an Ofsted that's inadequate. So automatically there is anxiety that logically all the effort goes into Wandsworth. And I think the Director of Children's Services in Merton makes that quite clear and will also specifically feed in and welcome the review so that we look at concrete issues and solve them collaboratively.
We did get the, at the Health and Wellbeing Board, we got the annual Merton Children's Safeguarding Board report, which was very good. And the chair of the committee was very complimentary about the Merton team and the level of engagement and joint working between the CCG and the council and the board. So I really must pass on congratulations to the team on that, particularly to Liz. And so that was very encouraging to hear.
I think because we've brought reports before, I haven't gone into the detail, but the report does show you a lot of the actual, what they've been doing over the year, not just the reporting mechanisms I've talked about. And there's a huge amount of involvement. You know, we chair meetings with the local authority. Liz, who our designate nurse, chairs the children looked after work that's done across NHS England for South West London. So there's a huge amount of work. She's absolutely respected and very well, Claire's nodding too, very, very well thought of. So I think we're very lucky that we've got such a strong person in that post.
So I guess probably the steer you were getting from the Merton CCG board is...
They want a bit more.
Well, no, we recognise that actually we're doing some things really well and we don't want to lose that.
I agree,
so
yeah.
absolutely we want to support Wandsworth and improve the quality of services there as well, but not at the expense of what we're doing in Merton. So we must hold on to what we've got and learn from that and spread it rather than diluting.
Thank you.
Any other? Dagmar.
Sorry, I've got 2 other points. One is around the Children and Social Care Act, which is a new legislation that follows the Wood Review, which looked at safeguarding boards and their arrangements, including CDOB, which is the Child Death Overview panel process. And it's just an alert that a consultation is going on now, how we are actually going to implement the new act. And I think it's really important that we do that jointly. The idea for the child death overviews is in particular that we are regionalizing it, because luckily numbers are relatively small, but in order to recognize pattern from which we can learn, we need a bigger footprint, and that is something that we really could and should look at STP level. So I'm inviting CCG to really make the best out of that consultation. That's the number one. And then number two, people will have seen it hit the press big time now. There is a real emerging issue of gangs and what is called county lines, which means often vulnerable youngsters getting groomed to be runners for quite big drug businesses. It's particularly in the outer London boroughs going out. That is an issue that I think the awareness amongst partners, health partners, primary care, we want to increase and improve. And there's the next Merton Partnership, which the CCG is a member of, will dig deeper to increase our understanding, because frankly we haven't got a recipe. You might have seen in the press, there's now finally the recognition. The Children's Commissioner, the National Children's Commissioner, has asked that we need a national strategy, because it's very tricky for a single borough to really get on top of that. It's a vicious problem. It's the very most vulnerable being groomed and abused.
Thank you for raising that for us, Dagmar.
Just confirming, we'd agreed as well at the Wandsworth Board that we'd do a joint review of the consultation, our feedback. So we can certainly do that with Merton as well, even if we join it up across the two, or if not, we'll do it with the council themselves.
Okay. Thank you. So we were asked to note the report, and I think you've had a bit of a steer from the board as well about what some of our concerns might be. So thank you, Julie, for presenting that. That concludes the items on the agenda. Oh, we haven't done it. Yeah, sorry.
Do you want me to do that? I'll do it very, very quickly. Sorry. So without going and repeating the same, obviously we've got obligations around safeguarding adults as well. And we do have a designated adult safeguarding adult nurse in post. So we have all of our roles filled within safeguarding adults. And we follow the Pan-London procedures around adults as well. So we've got our policies and procedures in place which do that. Again, I would say the same thing around looking at them across the two CCGs and working also with the councils. But I think we will be looking at how we do safeguarding across the Alliance when we have a meeting next week with our Alliance Director of Quality, because I think in each of the CCGs we're all doing very similar things that we could probably do a bit more efficiently. So we have a Safeguarding Adult Board. We're a statutory partner of that board, and we have absolute commitment to attending the board. So you will often have the executive lead as well as the designate, we don't call it designate, sorry, the adult safeguarding nurse as well. There's a lot of activity goes on within adults, and I think we used to focus a lot on children's safeguarding, but the remit of adult safeguarding is increasing and increasing week by week, really. So it is, again, another area that is really, really busy and something that we have a lot of commitment to, but does take up a lot of resource as well. There's lots of subcommittees of the board that we attend, and also there are, like we have children's serious case reviews, we do have the same kind of thing within adults, which is serious adult reviews, and we do also contribute to those. There's an operational group within Merton that sits underneath the board that does a lot of the business, and we contribute to that and often take on the leads for some of those work areas. A lot of detail in the report around performance again, but same message as earlier, that some of that will now be out of date. I think the area that we absolutely need to focus on is our prevent training. And this is training which is related to helping people who are identified as vulnerable and that may be radicalised, and there are procedures across the police environment that we need to link into and that we work very closely with. So the channel panel, as we call it, that sits within the community safety unit, and we absolutely have to make sure that our providers are doing the training in regards to the prevent training. And if there was one area I think that was of concern at the moment, it is making sure that we get that embedded into practice. St George's and South West London Mental Health Trust have both now had to do improvement plans for NHS England, which show how they will meet 85% of that training by the end of March. So I would say that that's probably the biggest concern that we have at the moment, that we will focus on. Other priorities would be the same around the protocols across the Alliance and managing the policies and procedures as well. So I'll stop there. There is a lot of information in the adult report. A lot of that is also pulled from the Merton annual report for safeguarding too. Happy to take questions. Most of the information you will have seen here before in quarterly reports, and it has been discussed at the Safeguarding Board.
Just one comment. With adult safeguarding, the learning disability mortality reviews have just come to the CCG, so that's just another area of focus as well.
Because it was last year's report. They started from April, but we have a process in place with the local authority where we do that with both boroughs.
Any other? Claire?
You mentioned performance management and quality assurance reporting. When will that be available in the format that's being described in the report? So when we look at how we get information around safeguarding numbers, I think it's fair to say that every CCG asks for it in a different way. So Merton and Wandsworth CCG have put together a proposal that we're going to be looking at next week with the Directors of Quality to see if we can do something like that across the whole of South West London, so that we're all asking the same questions, and so that when we go to St George's and ask for information, we don't have Sutton and Kingston and Richmond doing the same. We would give them the assurance, but between us we need to agree a format for doing that. There's one that works very well in North West London, so we've got one to look at, and we'll do that next week when we meet, and hopefully have that in place very soon.
Okay, so we're asked again to note that report, which we have done. So thank you very much. I am now, I think we're through all the items on the agenda. I did say we would leave some time for questions at the end, which is a bit constrained, but we haven't got any other business, so I have got 5 minutes for questions. So how many questions have I got? So I can't take 4. So can you tell me which item on the agenda your questions are about, and then we can focus in. So all of you. Yep. So at the back, you're... So A&E.
The model for mental health referrals that Dr. Sonia mentioned.
A&E, IAPT stroke mental health.
Item 5.2, specifically the SOC from
Epsom St Helier SOC.
The same item, but also I wanted to talk about the A&E figures.
Okay, so I think let's take a question on A&E. We have mentioned a bit about Epsom St Helier, so I think let's prioritise the A&E question and see where we get to. So do you want to just, if you give your question on A&E, and then I'll take yours, and we can see if we can answer it as one.
Thank you, Chair. Thank you. Oh, it's a bit awkward. It's fine. Thank you, Chair. I'd just like to ask, is it not true that the closure, perhaps, of either St Helier A&E or Epsom A&Es, but particularly St Helier, will have an adverse effect on the running of St George's Hospital, bearing in mind that it's already under special measures? And what do the board think, actually, of the petition that has been handed in by the COSH campaigners with regards to the fact that there are many, many thousands of people having signed that petition in support of St Helier and Epsom A&Es, and indeed the hospitals themselves. And yet the proposers of the reductions have only been able to find about 1,000 people to 441 signatures. If I can finish, please, Chair, I'll be very quick. They've only been able to find a very small amount of people to actually support this, and indeed they have absolutely failed to engage the public at all in this endeavour. And I wonder what you think about this.
Okay,
Thank you very much, sir.
So I think that question in some way links into the performance report where we're talking about A&E performance, and if one is to link it into an agenda item, it probably links in there. What was your question relating to A&E?
Well, two things really. I want to know what your reaction was. I gave you a petition with nearly 11. You said you wanted more interaction with the public, more feedback. There's a very significant feedback there, and it got absolutely no response from you at all. So it would be nice to hear what you think about those 11,000 people bothering to put their names and addresses before us. And there are comments there as well from the online one.
Okay.
But also, the A&E figures apparently haven't hit your target since August 2015, as it says in here. How is that going to be improved if we have a smaller, single acute facility instead of the two we currently have now? And you're going to have 500 beds instead of the 750 odd.
Okay.
How will that address the appalling A&E appointment?
So A&E performance, will we be increasing the risk if we do make any changes to services at local hospitals? What was your question about mental health?
Well, it was the way of referral you were talking about, that what if you sent off to these people and that was it?
I tell you what, why don't you pick that one up after the meeting, just in a conversation. What was your question?
Just before I put my question, a small admin point. I attended a meeting in this room a while back when we had a patient make a presentation, and a request.
Okay, so Sarah can reply to you on that now, I would think.
Well, I'd like a formal reply by email to COSH.
So I'll give you a formal reply now, and it'll go into the notes, which is exactly the same reply as I gave you last time, which is we haven't received any presentations on this because at the moment we have no decisions to make. If we go into a formal consultation process, we would be happy to hear from you as part of that process. And that was my response last time.
That's not a satisfactory.
Okay. I'm afraid if you want a response to your questions, I'm going to have to cut you short. Well, okay.
Owing to that discomfiture, which Lawrence Newman, the chairman of the board, obviously was aware of, when it came to him inviting the board to agree to submit the
Okay. So, Sarah, I think let's summarise the question. The Epsom and St Helier strategic outline case, what are we going to do with that? So what are next steps in dealing with that? Right. What is our response to the Kosh petition? And then maybe something in the time we haven't got, A&E performance, how do we anticipate any changes that are made impacting on A&E performance if we're already struggling? Okay. Could you tackle that in a minute or two?
I'll give it a go. So first of all, in part 2, we're not considering the SOC. We're talking about what would be the process. So that's why we're doing it in part 2. And we will come back when we have talked about that and present that and do that in public so that people understand what the process would be for us to take forward any decisions if we are going to make any decisions. So that's the first thing. So we're not actually looking at the SOC at all. So that's the first thing. And what there will be is there will be a process by which commissioners will consider everything, including the impacts on other providers, including the clinical model, including all of the options, and then they will, if they feel, when we have had all of those discussions and followed that process, that we might need to make a change to services, then we will fully consult with the public. So we will set out the process, and we will set out that we will do a consultation if that's required. So, and we have said that, I think, on numerous occasions, and that absolutely stands true. And as I said, part of the process will be to understand the impacts of any changes on other providers and other parts of the system. So that would be part of the process that we would follow. On the petition, it's quite difficult because you presented it today, obviously. That's a large petition. We would, as usual, accept a petition. If it's pertainable to anything that we're doing, then we would consider it. At the moment, we're not making any decisions on this. Therefore, it's quite difficult for us to respond to that. And obviously, we haven't had time to read it anyway. But we would certainly accept the petition on behalf of the governing body.
I'm gonna have to close the meeting. We have talked about that before. I think on the issue of how we respond to the petition, we'll need to have a look at that, and when we know what it says and have had a chance to digest it, we can make sure we respond. We will respond in some way. I think what Sarah's saying is that until we're actually consulting and know what questions we're asking, we won't understand what the implication of what you're saying in the petition is in terms of how it pertains to what we're looking at. But we will see. We will have a look at the petition because we haven't had a chance to do that, and then we will think about how we respond. Clearly, we accept it because you've given it to us, so we will have a look at that. I need to draw the meeting to a close because we're out of time. Thank you, everyone, for coming. Thank you for your questions and your engagement.